How many persons we have on live now?
71, 78.
Great.
Hello, everyone. Welcome to the Association of General Practitioners Pediatric Virtual Conference. It is so wonderful to have seminars on the little ones. And I bet you're going to find that it is going to be really useful. It is going to be thought-provoking and relevant to our daily practices. So at this time, I welcome Dr. Peter Swaby to bring us all to the throne of grace. Over to you, Peter.
Thanks, Aldith. Great to have everybody on. Thank you to all our sponsors. Let's go to God in prayer. Father in heaven, we are so grateful to be able to come before you today because we know that in everything, you are the one that directs and guides us and helps us in our work every day to do our best, and also, Father, to bring order out of chaos. Father, there are so many things that are not right in your world. And we as physicians are trying to right some of those things just in terms of our healthcare and our spiritual and emotional needs. And especially as we focus on children this morning, Father, help us to glean new insights as to how to better treat our patients, treat our kids. Help us also, Father, to have a heart of compassion, the same heart that you have for each one of us. And help us, Lord, to reflect what true Christianity is all about. Father, we're grateful for this association. We're grateful for all the sponsorship that we get. And we're especially grateful for all the speakers. May you be with them. And may you say a special prayer for our technology, that it will be free from glitches, and that we'll have a great presentation this morning. We love you. We thank you. We pray all this in Jesus' name. Amen.
Amen.
Over to you, Aldith.
Amen. And at this time, we invite Dr. Donald Gordon, the President of the Association of General Practitioners, to bring the welcome and opening remarks.
Thank you very much, Aldith. Good afternoon, presenters, Dr. Curtis Pryce, Prof. Christie, Dr. Shom Prince, our moderator, Dr. Buckland, my esteemed colleagues, and to our loyal sponsors, Indus Pharma, Nestle, Aristofarm, R.A. Williams, Abbott Nutrition, L2000. A sincere welcome back, and thanks for your continuing and loyal sponsorship to the association. Members of the AGPJ Secretariat and the technical support team of Allgate Solutions. I'm Dr. Gordon, President of the Association of General Practitioners of Jamaica. It is my pleasure to bring greetings on behalf of the association for this, our first webinar for the new year. It's an awesome pleasure to connect and renew and strengthen our professional relationship for yet another year. Before we go any further, we wish to record our sincere condolences to the families and friends of our colleagues who have transitioned in the last year and who are no longer here with us in the flesh this year. Without mentioning any special individual or any single individual, we have to make note of the passing of Professor Winston Davidson, who was a founding member and president of the association. Hopefully, their spirits are with us today. On a less somber note, a special shout out to the loyal and dedicated members of the executive whose selfless and dedicated service continue to keep this organization running. In this regard, we wish to recognize Dr. Buckland for opening the program, and also Dr. Swaby for the opening prayers, and to members of the executive and members whom we rely on for support from time to time. The association is delighted to start this year's series of webinars on the subject of pediatrics. In today's webinar, it is our intention to address a few of the common medical problems encountered by GPs in their daily interaction with the pediatric age group. This afternoon's webinar will focus on the topic of pediatric asthma, common upper and lower respiratory infections in children, and common fractures presenting in our daily practices. Hopefully, at the conclusion of this evening's webinar, the accompanying discussions and the question and answer session, we will be able to unravel and gain a better understanding of diagnosing and treating pediatric asthma, master the management of upper and lower respiratory tract infection in children, and readily recognize the presentation of common fractures occurring in the pediatric age group. In closing, we in the association sincerely hope that this evening's webinar will meet its objective of informing us on the topics that we address. And we also hope that it will be a springboard for the success of future webinars in the years coming up. Thank you very much, colleagues, sponsors, presenters, and other attendees. Our sincere blessings to you in the new year. And we hand over back to Dr. Buckland, our moderator. Thank you very much.
Thank you very much, Dr. Gordon. At this time, I invite Nestle Jamaica to show us what they want us to know. Over to you, Nestle.
Good afternoon. Thank you for inviting us to participate in your conference today. It's a pleasure for us at Nestle Jamaica to be a part of the AGP conference. We will share with you just a few highlights from our product line that would be beneficial for your pediatric population, and just to show you our stance when it comes to breastfeeding, because breastfeeding remains the most important part of infant nutrition growth and development to start. So you can start the presentation. Thank you.
Greetings on behalf of our Nestle family and welcome. At Nestle, we support the World Health Organization's recommendation for exclusive breastfeeding during the first 6 months of life and continued breastfeeding as long as possible. Our Lactogen infant nutrition solution contains gut-friendly ingredients that promotes a balanced gut microbiome and helps with several gut-related issues. It contains L-Reuteri, a probiotic clinically shown to improve gut microbiota by increasing the number of beneficial bacteria. The combination of lactose and magnesium helps promote softer stools by increasing the amount of water in the intestines and help with bowel movements. Its unique fat blend combined with L-Reuteri also promotes stooling pattern closer to that of breastfed infants. The mix of prebiotics, probiotics, and lactose included in our Lactogen formulation helps to foster good gut microbiome balance. This helps with several GI issues.
Grow happy, sha-la-la-la.
When her tummy is happy,
It's so nice to grow happy, sha-la-la-la.
the entire family is happy. And it all starts with Lactogen 3 with Comfortus Grow. Lactogen 3 contains probiotics that supports her digestion, digestive comfort, and defenses. And it's easy on her tummy.
Just Lactogen to grow happy.
Lactogen can help you manage and prevent the challenges your little patients go through from 0 to 36 months, making their gut microbiome power stronger for a healthy and happy growth.
At Nestle, we also feature another solution whenever breastfeeding is not possible. This solution builds on our knowledge learned from Lactogen and adds even more features identified during research. Nestle's Non-OptiPro features a staged approach with our exclusive combination of OptiPro, resulting in protein optimization for efficient delivery in quality and quantity of proteins, coupled with probiotics, DHA-ARA, and the 2-FL-HMO.
Lactose intolerance results from a reduced ability to digest lactose, the main digestible carbohydrate in mammalian milk. This happens when there is insufficient lactase to break down lactose for absorption by the body. The fermentation of undigested lactose can lead to gastrointestinal symptoms similar to symptoms of cow's milk allergies. Some of these symptoms include abdominal pain, diarrhea, bloating and abdominal distension, flatulence, nausea, among others. Clim 1 Plus lactose reduced solution is specially designed for children 1 to 3 years. It helps to reduce digestive discomfort that occurs as a result of lactose intolerance. It also allows toddlers with tolerance issues to continue receiving the nutritional benefits of dairy consumption. Clim lactose reduced solution has a 90% reduction in lactose. Let's look at what this reduction means using common dairy products and the serving size for each. Milk contains 15 grams of lactose per serving, 1 cup. Ice cream contains 4 grams per serving, half cup. The 90% reduction of lactose in Clim equals to 0.9 grams per serving. This is a small amount of lactose when compared to dairy products on a per serving basis. This amount provides half of the daily recommended intake of lactose for toddlers. Clim 1 Plus lactose reduced solution also contains Lactobacillus protectus, a probiotic, and contains prebiotics. It is fortified with vitamins and minerals to help to support growth and development of toddlers. General treatment principles of lactose intolerance include continued breastfeeding in breastfed infants. In formula-fed infants, a limited trial of lactose-free formula may be indicated, for example, following viral gastroenteritis. Lactogen soy can be a suitable treatment option for this general treatment principle. Other treatment principles include reducing but not eliminating completely the intake of lactose-containing foods. Also, introducing small amounts of lactose in divided doses daily. And in older children and adolescents, introducing up to 12 to 24 grams of lactose in divided doses daily, which is usually tolerated. Clim 1 Plus lactose reduced solution can provide the support for these additional principles. Clim 1 Plus lactose reduced solution is the perfect addition to our Clim line, adding that specialty option. Our Clim 1 Plus solution is for 1 to 3 years, and our Clim 3 Plus solution is 3 to 5 years. Clim is a milk-based growing up product that helps to support the normal growth of toddlers with prebiotics, vitamins A, C, D, zinc, and selenium to contribute to the normal function of the immune system. The complementary feeding phase is very important, and foods added during this period should provide sufficient energy, protein, and micronutrients to bridge any nutrient gaps. It is important to note that the amount that a child can eat is dependent on the capacity of the stomach. At 6 months, the capacity of the stomach is 230 grams to 250 grams, which equates to around 78 ounces. Cereals are a great source of energy and other nutrients needed for growth. Infants require 2.3 times more energy than adults. From 8 months, carbohydrates become the most important source of energy, and grains are great sources of carbohydrates. Iron deficiency is a major cause of anemia among preschoolers, with an estimated 4 out of 10 children suffering from anemia globally. Nestum cereals are perfect for complementing breast milk and other traditional complementary foods. Just 2 bowls per day will provide the necessary nutrients to bridge the nutritional gap. We have several cereal offerings that provide nutritious combinations of ingredients and provides the baby with a more varied diet from 6 months of age. Our starter infant cereals include rice, which is our first cereal, as well as oats and rice. Our Nestum toddler shakes comes in 3 amazing flavors: vanilla cinnamon, chocolate, and strawberry. We also have our complete cereal, which comes in the form of Cerelac. Cerelac already contains milk. Here are a few of the references used throughout this presentation. If you have any questions, please feel free to contact your local Nestle representatives.
Thank you very much, Nestle Jamaica. Your products are quite tasty. I've had them even as an adult and as a little girl. And
Thank you.
And my kids have had them too. And I've seen other children enjoying them, you know. So they do have a very important relevance in our market. And I'm glad that you also indicated from the outset that breast milk is very important for kids to be fed exclusively for the first 6 months of life. Well done. Thank you so much.
Thank you for inviting us.
Oh, you're so welcome. And your invitation will be open to any conference you'd like to support. Thank you so much again. Now, Dr. Curtis Pryce. He is in our lineup of speakers for a very special reason, because he is going to bring a very dynamic presentation on recognizing and treating pediatric asthma. So who is Dr. Curtis Pryce? I can only tell you a little bit about him. And what I know is this: he is the president of the Pediatric Association of Jamaica. He's a pediatric consultant at the Maypen Hospital, an undergraduate and postgraduate studies at the University of the West Indies in pediatrics, and presented at various conferences locally and internationally on various pediatric and lifestyle topics, including asthma care of the pediatric patient. He's an associate lecturer at the University of the West Indies, Caribbean School of Medical Sciences, Windsor School, and AAIMS. He has a passion for teaching and passing on important clinical skills to upcoming generation of doctors. Wow, he's married twice. He's married twice, first to Christ Jesus and then to his wife Ellarine, and has 2 adult children. He enjoys playing badminton and working for the Lord. His mantra is, "Let Christ be first, others next, and myself last." Well, I'm going to invite Dr. Curtis Pryce to take it over, and you're the first batsman. Bring us recognizing and treating pediatric asthma. Over to you, Dr. Curtis Pryce. Thank you so much for being here.
Good. What is it now? Good afternoon, everyone. And I would like to thank the association for inviting me to speak on this very important topic. Give me 1 second. All right, so sorry about that. So it's a pleasure to be asked to present on this very important topic, this very common topic in pediatrics. And I must commend the association for highlighting children, you know, in this forum. So today we'll be talking about asthma. Today I will be talking about asthma and specifically looking at asthma in the pediatric population. And I would like to thank Doc for her kind words of introduction. All right, so we'll start out by looking at a definition for asthma. Asthma is defined as a chronic inflammatory disease of the airway, which is characterized by varying degrees of bronchoconstriction and airway hyperresponsiveness. And this leads to airway obstruction that is reversible. Hyperresponsiveness is defined as a child's predisposition or the predisposition of the airway of patients to narrow excessively in response to particular stimuli that will produce little or no effect in a normal, healthy individual. Now, there are various challenges concerning pediatric diagnosis, the diagnosis and management of pediatric asthma. The fact is that pediatric asthma is common and, you know, right across the world in all population groups. We have studies showing up to 14% and even up to 30% of cases. There are also many contending diagnoses. So we know that children have respiratory tract infections. You know, the parents are usually very bothered by these frequent exposures, especially when they go to daycare. There's difficulty with diagnosing asthma, especially in the young patients. Of course, we have in adults, it's just adults full stop, but in the pediatric population, we have different age group. As you know, children, you know, you have the neonates, you have the infant, you have the older child, you know, so you have different age groups to contend with and hence different treatment strategies. The complications of therapy, especially with respect to, you know, the growing child, is more significant in this age group compared to adult population. Of course, dependence on the caregivers to provide information. These informations are usually important for diagnosis and also for management of the patient and also for, you know, eliciting when a child is, say, having a breakthrough. And so it's highly dependent on, you know, somebody outside of the child. Of course, the child's inability, especially younger child, to express exactly what they're feeling and what their symptoms are. All right, so these are some of the difficulties and concerns that we face. So for years, asthma specialists thought that asthma was one entity. Recently, however, various research have confirmed that there are various what we call phenotypes and endotypes with respect to asthma. A phenotype can be seen as, you know, phenotype usually describe what you look like. So the phenotypic characteristics for asthma usually concern the clinical presentation, various triggers, and also response to treatment. There's another subclassification of endotype, which usually is the immunological or the pathophysiological mechanisms. And it has been classified as a type 1 or a type 2 endotype. All right, so there are 6 main phenotypes with respect to asthma. The first one is the allergic asthma. So in this asthma, which is the one that we are most familiar with, there are environmental allergens which trigger asthma. And these might be the common ones like pollen, dust mites, etc. This accounts for 40 to 50% of asthma presentations. Allergen testing for environmental allergen become important in this type. Of course, your CBC may elevated eosinophils called eosinophilia. Antibody testing may show elevated levels of IgE. And of course, your fractional nitric acid test may be positive, expired nitric acid. In this scenario, the management will involve antihistamines, allergen avoidance, allergy immune therapy, biologics, which is has become quite topical and useful in the management of asthma. Not so big in Jamaica, I suppose related to the fact that these drugs are pretty expensive, but in a lot of first world countries, they are used widely to manage these children with allergic asthma. And of course, there's the non-allergic asthma, where there's no sensitization, no allergens involved. And of course, the fractional exhaled nitric oxide is usually negative. There's another type called aspirin sensitivity. This is a less common type. It's triggered by NSAIDs, so your aspirin, your brufen, those medications, and it's characterized by chronic rhinitis and or nasal polyp formation. They may also have an increased eosinophil, and it's treated with the treatment is targeted at the immunological pathways that is stimulated by the NSAIDs. There is a rare one called neutrophilic asthma, which is most common in patients with severe asthma. So it's rare, but it's significant for the fact that in patients with the severe difficult to control asthma, neutrophilic asthma tend to predominate. And in this scenario, they have high levels of neutrophils in the sputum. Of course, most of us would be familiar with exercise-induced asthma, as the name suggests. You have tests indicating airway reactivity with exercise, with reversibility with bronchodilators. And of course, you treat with medications prior to the child participating in vigorous activity or just exercise in general. Some note on the phenotypes, even though we have this distinct category, many of these the patient may change over time. And also 2 phenotypes may exist in an individual at the same time. This, I think, is the area that most physicians and medical care professionals are particularly concerned and confused about: the diagnosis of asthma in the pediatric age group. Diagnosis of asthma depends on the age of the patient. It depends on the clinical symptoms. It also depends on lung function testing, your peak flow on your spirometry. And it also depends on, fractional expired nitric oxide, which is not commonly used, in the pediatric population. Let's look at how you diagnose asthma in the different age group. Remember we said in the pediatric population, we have these different ages that we have to contend with. So how do you diagnose asthma in a child, 1 to 5? So the patient must have recurrent wheezing. The diagnosis is made based on, or in a patient with recurrent wheezing, the diagnosis is made based on signs of airway obstruction or convincing report of the same. So, a parent, reporting a clinical scenario indicating airflow obstruction. There also must be reversibility of obstruction with asthma therapy. So a child comes in, he indicates, or there's cough and congestion. He's treated with, say, a trial of SABA, and SABA is your short-acting beta agonist, and the child responds significantly. There's good response to a therapeutic trial of inhaled corticosteroids. So you have a child who has, recurrent wheezing, they're treated with SABA, every month they come in, they have these, a viral infection or whatever. You suspect asthma, you give them a trial, a therapeutic trial of, say, inhaled corticosteroids over a 6-week period, and it makes a significant difference. So in the absence of, and of course, this point is very important. These occur in the absence of clinical evidence of an alternative diagnosis. So in your history, and of course, we know history is very crucial to the management, well, for clinical management in general, but even so for the pediatric patient with asthma. You need to take a thorough history to ensure that you're not dealing with some other entity that is contributing, to asthma. So you talk to the parent, and this child has recurrent cough with a lot of sputum, he's losing weight, he's failing to thrive, he has, thrush in his mouth. When you're examining, he has clubbing of the fingers, then, you should consider an alternative diagnosis. Of course, a personal and family history of atopy heightens the suspicion of asthma, but it's not absolutely necessary for the diagnosis. So you may have a child, and when we say atopy, I think most of us are medical professionals here. We're talking about your allergic rhinitis, eczema, those allergic sort of presentation. Even though they're common in children with asthma, they're not absolutely necessary for the diagnosis. All right, so in this age group, children frequently present with recurrent wheezing. And of course, this is particularly so in the child 0 to 2 years. This is usually viral-induced wheezing, and they may occur up to 6 to 8 times per year. For those of you who are also have children, we all went through this. Your child is at home, he's fine, you take them out to daycare, and this child is having a cold like forever. Sometimes the parents take the children to the office and they say, "Doctor, he's having cold for 6 months. I treat him, he get over it, and he like he never out of this thing. And every time I take him to school, he gets sick again." So this episodic wheezing pattern is common in children less than 5 years. And added to the fact that diagnostic tool utilizing airflow limitation cannot be used in this age group. So therefore, a symptom-based approach has been suggested as a guide to assessing asthma in this young population. All right, so we kind of divided into 3 categories. If you have a child who presents with a cough, wheezing, heavy breathing, with an upper respiratory tract infection, and Prof will be looking at this later, lasting less than 10 days. There are 2 to 3 episodes per year, and there are no symptoms in between the episodes, then we say asthma is unlikely. However, if you have the same cough, wheezing, and heavy breathing with an upper respiratory tract infection, it lasts for more than 10 days. They are greater than 3 episodes per year. The child presents with a cough, wheezing, heavy breathing, occasionally in between the episodes. They have nighttime worsening, and they present with one of these episodes being very severe. Then we say some of them as asthma. we have a child presenting with similar symptoms lasting again for greater than 10 days, 3 or more episodes for the year, having, cough, wheezing. They have heavy breathing during play or laughter. And this is a common presentation for children with asthma. They have nighttime worsening. They present with a severe episode and a strong personal family history of atopy. Most of these children will have asthma or has asthma. The differential diagnosis, as I hinted on before, is a long list. All right. But some of these, sorry about that, you will note include your viral respiratory tract infection, which is pretty common, a bacterial pneumonia, chlamydia infection, a walking pneumonia, they call it. Aspirations commonly occur in children, sometimes unbeknown to us. A child may aspirate and, cough, and sometimes cough for a long time, without being aware. Children also have reflux disease, gastroesophageal, and you have to ask, for these symptoms, these positional symptoms, and sometimes food-related symptoms. In heart disease, we usually refer to it as cardiac asthma. Children can present with wheezing related to heart failure, related to their cardiac problems. And of course, there are a multiplicity of congenital lung conditions, such as your cystic adenomatoid malformation, bronchial lung cyst, emphysema, and so on and so forth. And we look at diagnosing asthma in children greater than 5. This is based on symptom variability. Remember, variability is a very strong requirement for asthma. You should be cautious about diagnosing asthma in a child or anybody who has, no variability of their symptoms and variability in terms of responsiveness. Symptoms vary with time of day, right? So children tend to get worse at night. Symptoms varying in intensity, over time, and their variation in exposure. For example, a child who is active, the symptoms may worsen, laughter, exposure to allergens, and various infections. So we're talking about the variability. All right, so diagnosing asthma. Okay, so we say it's based on variability in lung function. I kind of categorize them in terms of the lung function test, moving from normal to improved with what the test is called the bronchodilator response test. So the child is having bronchospasm, you expose them to a bronchodilator such as a SABA, and the child goes high, meaning he has improved, he has opened up. You may have a child, with similar presentation, he's having his bronchospasm, you expose him to an inhaled corticosteroid, and this is diagnosis we're talking about. Give them a trial of inhaled corticosteroids, say for 4 weeks, and there is significant improvement in their symptoms then that aid the diagnosis. The child may be exposed to, we don't frequently do this in children, but the bronchial challenge tests, such as a methacholine or a hypertonic saline, or even mannitol, and they move from what I call a high to a low. And of course, peak flow variability over a 2-week period or between visits. And finally, also there's documented airflow expiratory limitation, and that is indicated by a FEV1 over your forced vital capacity. All right, so after you have gone through, the torture of diagnosing this child, what do we do? After asthma is diagnosed, the child must be treated based on the severity of his illness. So we need to categorize this child based on, severity. Severity assessment is based on two important entities. These include what we refer to as impairment to the patient's functioning and risk of future exacerbation. All right, so we're trying to predict the child's risk of a future exacerbation, and we're looking at impairment of their daily life. This should be done prior to you starting medication. So you placing the child in a severity category ideally should be done before the child starts, his treatment, especially the maintenance treatment. However, most of the time we might get a child in the office who already started treatment. So it's difficult to use, your that initial assessment. So what we do instead is that we look at what is called the control of the child's symptoms, and also that has two entities, namely impairment and risk. All right, so these are the charts that we're accustomed to seeing, and so this is the severity assessment. So looking just at the impairment portion of it, it usually has some combination looking at nighttime symptoms, response to medication, interference with clinical activity, use of the bronchodilators, use of steroids, and that sort of thing, meaning oral steroids, right? Sorry, the impairment. And then the risk now will look at also the use of medication, meaning the risk of a future exacerbation. All right, so it's a consider severity and interval since the last exacerbation. Frequency and severity may fluctuate over time. So for your risk, you're looking at the patient's exacerbation requiring oral corticosteroids, right? So those patients are, so you have a patient who has used oral steroids to manage their treatment or their asthma 3 times for the year. That child is placed in a high risk category. When we're placing the patient, when we're categorizing the patient, you use the one that is worst. All right, so for example, say we have a child who is intermittent for symptoms, and he is intermittent for use of medication, but then he's severe for using corticosteroids. Then you put them in the severe category, right? So it's not an average. Okay, so this chart shows, is based on the asthma control test. All right, so remember we said that after the child is diagnosed, then, you obviously can't use the severity measures to monitor them. So we use, what is called the asthma control test. Okay, which is a self-based test where the patients can read through and kind of they can do it themselves. Indicate what is happening to them. There's a score, and it will place them in in various categories. The asthma control test also has components of impairment and risk, and as you see, it looks pretty similar with respect to what is assessed. There are asthma control questionnaires, and some of you might be wondering, there's an asthma control questionnaires, there's an asthma control test. The asthma control questionnaire usually the scores are usually lower, 0 to 6, and the higher the score, the worse, the patient. And then the asthma control test, a higher scoring system, 5 to 25. And in this case, higher is better. So the asthma control questionnaire, higher is worst. We said that already, different for different age groups. If you look at this one, you'll see where, you have the asthma control questionnaire, the asthma control test, there's a score, and, you're able to assess the degree of impairment and risk. All right, so you might have heard about the stepwise approach to managing asthma. Basically, the treatment given is organized in terms of steps. There's a system that has steps 1 to 6, but the GINA, it's 1 to 5, right? So this is a stepwise approach to treatment. The treatment given at each step varies depending on the age of the patient. So the steps are different for the different age categories. Right, and you don't need to memorize them. A good thing would be to just copy, some of the charts and put it in front of you so you can have a visual and you can place them in the categories easily. All right, so based on the severity, it determined at diagnosis, the patient is started at a set step. All right, so the categories of severity, as indicated above, you have the intermittent patient, then you have the mild, moderate, and severe persistent patient, right? And then with respect to the stepwise approach in terms of treatment, you have the step 1, 2, and 3, 1 to 5, all right? So an intermittent patient, based on their subsequent control score, may move up to another step on review. These are the steps, all right? This is the GINA, based on the GINA guidelines. So you have the step 1 to 5, and they tell you what medication is recommended as first line for each step, okay? And then and then they also have what is called a track 2. So track 1 is the, the primary recommended treatment, but track 2 is the alternative, treatment. All right, so as we look at the different age groups, just going to go through this quickly. They are available, printable charts and stuff are available. So, just print them and go through, right? So for step 1, it's recommended that you for the 6 to 11 years, you use your low dose inhaled corticosteroid. So let's just summarize it quickly. So for step 1 to 3, inhaled corticosteroids are recommended. Okay, so kind of just summarize it like that. 1 to 3, inhaled corticosteroids are recommended. But step 1, you use your low dose inhaled corticosteroids whenever SABA is taken. All right, so the child is having an acute attack at step 1. They take their SABA, so you take a Ventolin, and it's recommended that you take your inhaled corticosteroids whenever you take your Ventolin. That's step 1. All right, so step 2 now, again, inhaled corticosteroids, but this inhaled corticosteroid is taken daily as a low dose maintenance. Remember, so 1 to 3 is inhaled corticosteroids. Low dose, step 1 is intermittent. You take it when you're having symptoms. Step 2, you take it daily. Step 3 now is mixed. So GINA recommended inhaled corticosteroid with a LABA, all right? Or they step up to a medium dose inhaled corticosteroids. And for step 4, you use a medium dose inhaled corticosteroid LABA, and so on and so forth, right? So once you get the essence of, the whole management system, you don't have to swat it. We have a lot to remember. Put it up on your wall and refer to it. After a while, it becomes easy, right? And of course, they have the, alternative treatment that is recommended. What asthma management these days are targeting, are looking at, is an individualized approach, all right? To management. So, a child may may not be comfortable with, or the parents, or whoever. So we try to individualize the approach as much as possible. All right, so for the children 5 years and older, you can review it again. And sorry, 5 years and younger. This one is the tricky one. All right. Actually, this chart is a 2022 guideline, but I'll just tell you what the current recommendation is based on the 2023 guidelines. For step 1, all right, they have preferred control and nothing is there. But what is recommended or suggested is that if you have a child 1 to 5 for step 1, and they have recurrent wheezing with a respiratory tract infection, you could actually offer to give them a course of inhaled corticosteroid to cover the course of the respiratory tract infection. For step 2, low dose inhaled corticosteroid is given daily, so it's similar to what we did for the 6 to 11. And of course, for step 3, you double the low dose. These are tinier children, so you have to be cautious with use. For the younger children, they don't have a step 5. So step 4, you continue the controller therapy and you refer them to specialist care. I wanted to show a chart showing the relative amounts of inhaled corticosteroids that is recommended. As I said to you, children are packaged in different age categories, not one size fits all. So we have our less than 5-year-olds. The dose is different for a 6 to 11 and also for greater than 12. And this chart you can also print and put on your wall so that it can remind you. If we look at fluticasone, we see the daily dose is 100 micrograms for that age group, right? For the 6 to 11, we have low, medium, and high dose. And of course, the stepwise approach will indicate which category, and you use that to decide what dose you give your patient. Follow-up is very critical for these patients, and it is a cyclical approach. You always should continuously assess your patient, adjust the treatment, review their symptoms, and you do that over and over again as you manage the patient. So you see the patient for the first time, the assessment, you review your diagnosis. You assess symptom control, lung function test, is indicated. Assessing risk factors to this child, looking at factors affecting adherence, looking at inhalation techniques, and we're going to look at some of that briefly later, looking at patient adherence, right? And you adjust the medication as necessary and always review with the patients, their symptoms, exacerbations, side effects of medication, growth, patient needs to be measured and, and that sort of thing, looking at patient satisfaction. Something as simple as a child told me that this thing was so bitter in his mouth that he refused to use the medication because it tastes bad. Do you understand? And of course, that is definitely going to affect adherence. With your follow-up, there is a step-up or a step-down approach depending on the control over 2 to 3 months. You step down to the lowest dose to control the patient's symptoms. And you try not to do it too dramatically. You try and reduce, the medication by about 25 to 50% at a time. If there is a mild acute exacerbation, some of the suggestions are that you may quadruple the dose of the inhaled corticosteroid for those who are on SABA as controller. So they're on, 50 micrograms, you're 4 times that dose. during acute exacerbation. And of course, we're going to talk about our charts later. If you also quadruple the inhaled corticosteroid for Motorol, if they're on SABA as controller. And you step up to a higher dose if they're on inhaled corticosteroid, non-formoterol. I will stop here quickly to just emphasize the point. I think we went over that slide quickly, but in terms of the adults, in terms of adults and children over 12, for the different steps, inhaled corticosteroids for Motorol can be used as maintenance and reliever therapy, what is referred to as MART. So, some of you might have heard, SMART or MART going around. Basically, what they have come up with is this novel presentation of an inhaled corticosteroid mixed with a LABA, and the specific LABA is for Motorol, right? So you have that combination, and it can be used both for maintenance therapy and to treat an acute episode. That is recommended, meaning the SMART, single maintenance and reliever therapy, or MART, maintenance and reliever therapy. That preparation is only recommended for children over 12. You can use the combination for maintenance in children under 12, but not for MART. You can't use it for maintenance and reliever in a child less than 12. All right, so as I come to the end, just quickly looking at some very important concept, your spacer device. So to go through the, indicate to the child and the parents how to use their device in, their cyclical reassessment of the child. Something as simple as taking off the cap of the inhaler. I've had a child who the mother was spraying the medication inside the child's nostril, and she was coming to clinic for a long time, and she was doing that. And I don't know, everybody assume, so we never assume. Ask them to take their medication and demonstrate. She was spraying it in the nostril. All right, and this child wasn't responding at home, but responded at the hospital, and we wonder what was going on. So your spacer device is called a holding chamber. If I'm out of time, please indicate to me. So, this is called a holding chamber. So basically, you ask the child, you take out the cap, you attach it to the bottom. There's a little adapter section at the bottom of the spacer. For a child over 5, we recommend using a mask with this spacer device. And a mouth, the older child can use the mouthpiece without the mask. Okay, so you ask them to open their mouth, put their tongue under, put the mouthpiece between the teeth. You have to deliberately say those things because sometimes the tongue might be in the way, blocking the flow. You shake and you have to activate the meter dose inhaler. So you shake it and you spray it 4 times for those who are using it for the first time. Then you do 1 spray in the chamber, and prior to that, the child breathes out. You put the spray in and they breathe in and they hold it for 10 seconds. So just count to 10. All right, so that has to be done. And when you reassess your patient, reassess compliance, reassess their response to treatment before you step them up, to a higher level, make sure that they're using the equipment appropriately. And of course, cleaning is important. So you're supposed to use warm soapy water to clean the device. Do not use cloths to wipe it clean. Leave it to air dry because the lint that is attached to the inside is going to affect, the medication availability to the patient. Change the spacer at least once a year. Some people recommend even every 6 months. because it's plastic, it decays, it gets affected with age, and will affect the medication available. This is a peak flow that we spoke about earlier. Usually it's recommended that you use it especially early in the treatment, and for children who are not aware of their symptoms. You have some children who are wheezing like crazy, they're not coughing, and the parents are not aware that they are having an attack until it's very late. So the peak flow, is very useful, especially in children like those. And of course, it helps with diagnosis. And, to go through the peak flow reading, it's a similar sort of thing. The patient must be standing. You put the mouthpiece in between the teeth, wrap your tongue around, put your tongue underneath, wrap your lips around it. You take a deep breath in and then blow out as hard and as fast as possible. And you do that when they're not sick. So they're not to be coughing or having anything suggestive of an acute attack. And you record that reading. You do it over a 2-week period, every morning and evening, and we take the highest reading, and that will be their personal best. That is used to place them into, the mild, moderate, and severe categories. Quickly, this is your asthma action plan. And this is a plan that helps the child and his parent to be in control of his asthma at home. We describe it in terms of, a stoplight system, where the green is for go, the yellow is for caution, and the red is for stop. In the green section, so you write numbers at the top, telephone number, emergency contact, the doctor, that sort of thing. In the green zone, the child is well. So in summary, it's a well child not having any symptoms at all. So you write that, if the child is on controller therapy, you indicate what the child is to take. In this section also, we look at, exercise-induced symptoms. So you indicate to the child or to the parent, you are to take 2 puffs of the Ventolin 15 to 20 minutes prior to exercise, especially for those who have exercise-induced symptoms. In the second category, the caution, they are coughing now and symptomatic. So I would say they would be, mild to moderately symptomatic, and you tell them what to do. You're going to take your SABA, or whatever the stepwise approach is you have selected for that patient, and you tell them what to do to increase when they're having symptoms, and so on and so forth. Some people think that oral corticosteroids is not a part of the home management, but it is. If you have a child who, as we said, you might quadruple the corticosteroids while they're having an attack, and after 2 days, there is no significant response, there is a recommendation that you can actually ask them at home to take a course of oral corticosteroid for 3 to 5 days, and of course liaison with you and come in for a quick interim review. This top area is where the child is very severe, is having difficulty breathing and talking, is critical. You need to advise this child to, double up his medication, 6 to 8 puffs of the Ventolin, the SABA. You repeat it as necessary. Well, not as necessary, repeat it every 20 minutes or so until the child, gets to the hospital, gets help. And the nebulizer, a lot of the parents, they like the nebulizer, right? But it's not something that, we use it for a last resort. There's some children that, may need it, very few at-home treatment. Please remember that, the aesthetics of it, it needs to be cleaned and, washed properly to control infections. But also something that many of us don't think about is the risk of glaucoma that the nebulization solution can cause on the eyes. The eyes of the child needs to be protected. We recommend, instead of a face mask preparation, that you use the nebulizer with a mouthpiece. So that will prevent excessive, exposure of the child's eyes to the nebulization solution. I think I am finished here, and these are my references. Thank you very much, and thanks for accommodating me.
Thank you very much, Dr. Pryce. I told you that we were in for a feast, and we were definitely in for a feast. You know, I remember I was in the emergency department and this kid came in. And then I listened to the kid and on the chest, and I heard a lot of wheezing. And then something that I usually do, I just want to know where along in the airway was this problem. So I asked the kid, breathe through your nose. And I listened to the chest, heard a lot of wheezing. And then I said, well, now breathe through your mouth. No wheezing. So where was the obstruction? Right, it was all up here. So I just needed the saline. So not all wheezing is asthma. Dr. Curtis Pryce, we have some questions that you're going to help me to help our people to answer. Okay, from Sherneth Heslop Barnett. What if the child is not wheezing but coughing persistently?
Right. So children, a lot of children with asthma, they present with, with persistent cough. All right. Which is a sign, of bronchospasm and inflammation. So they might not indicate, that they're wheezing necessarily, but they have cough, previously referred to like a cough variant, sort of presentation. The fact of the matter is that there are a long list of causes of a cough in children. And the cough has, based on the presentations, you have to take a thorough history. So a child who has, allergic rhinitis symptoms, is rubbing the nose, is sneezing, is having postnasal drip, the cough comes on when he lies down and that sort of thing. This child may have allergic rhinitis with a postnasal drip. Gastroesophageal reflux can actually cause cough. And some people might not be aware that, you don't have to have the gastric juice coming up and dumping into the lung. You can have what is called reflex bronchospasm, where just the, the acid and the stomach content coming up into the lower esophagus. There are cough, what do you call those? There are things that stimulate cough right at the bottom there, and it can trigger up of a cough. So not everybody who is cough, TB can present with cough, respiratory tract infection. So the history is actually important, in terms of assessing whether or not this cough is truly related to asthma or not.
That is true. And you mentioned in your slides that the nutrition was important because you do have nutritional triggers. And when we look at what parents are putting in their kids' snack box, cheese tricks, this, that, we can see a lot of things that can be potential triggers. And in this time of climate change, when things are hotter, we wonder how many water breaks the kids are being allowed at school, because it's so important to keep well hydrated. Don't you agree? That children should keep well hydrated in school?
Certainly.
The next question here. A male child who is 3 years old has a constant cough at nights for many months, and that the attendee says there are no other symptoms. What possible cause could this 3-year-old male child have who has a constant cough at nights?
Okay, I think I kind of, looked at it. As I said, that history, is very important. What preceded the cough? How long has this cough been going on? Is it a cyclical cough? Does the child cough when the apple tree is blooming, you know, does he have the cough only during the winter season? You know, does he have a postnasal drip? So, you know, those differentials you really have to go through and explore adequately before, you know, making that diagnosis. Somebody
So,
said mango tree, certainly.
right. So, Dr. Pryce, then it would come down to what sort of kid would have this problem. So we need to look at the environment, what the kid does, what the kid eats, the kid's emotions. Is what sort of kid would have a problem, and then work it like that. You know,
Yes,
because because as you mentioned, there are so many triggers. But if we can look at the individual, the family, the home, the environment, the everything, the whole holistic approach, then we will come to a diagnosis.
Yes.
Dr. Alert from Barbados, welcome, my friend. He's asking, do you recommend family physicians do bronchial challenge tests in their offices to diagnose asthma in a child who is less than 5 years old? Should family physicians do bronchial challenge tests?
Yeah. You know, the thing is that in a child less than 5, you said?
Yes, that's what he's asking.
Yeah, no, it's not recommended in, you know, in children less than 5. Those tests are recommended for children over 5. And even with that, you know, the bronchial challenge test is a little limited, you know, in children in general, but certainly not in a child less than 5.
So if the kid is over 5, what precautions would be necessary in the office prior to doing such a test?
Well, the thing is that we usually refer these patients for their diagnostic in terms of the spirometry, you know, and that sort of thing to the pulmonologist, right?
Right. Team approach. It's a team
yes,
approach.
It's a team approach. So I wouldn't necessarily recommend, you know, doing it in your office. The other challenge test, well, it's not a challenge test, where you give the bronchodilator test. I mean, of course, you can do that in the office. That's what we do every day. We see a child, we suspect that he, you know, might be, and we give him the challenge, we give him a nebulization, and we review him. So that is acceptable.
Right. Okay. This attendee is asking, which is better in asthma to use at home? Should you use a regular air filter? Should you use regular air filter, a humidifier, or air conditioner? Or does it really matter?
All right. So they have done a lot of studies, you know, with respect to your air conditioners and the filters, you know, and that sort of stuff. What they have found is that because these allergen and allergen sensitization is so ubiquitous, you know, a lot of times, I mean, if you can, you do them anyway, but they don't add a lot in terms of, you know, long-term outcome, you know, and that sort of thing. The air conditioner, you know, can be used to help to reduce the allergen, you know, in a particular environment. But the air conditioner itself, if it's not properly managed and properly cleaned and that sort of thing, can come back to hurt you, right? Because you can, you know, breathe a lot of fungus and spores and that sort of thing, which can end up, you know, exacerbating the asthma.
Yeah, and they found quite a bit of well, I don't know about homes, but maybe even in homes, because if the homes are in a very wet area, they may have mold too.
Yeah,
so
definitely.
The mold may be circulating. This doctor says that she uses a mask with a spacer. Using a mask with a spacer, is that okay? Or you mentioned about using the mouthpiece with a spacer.
Yeah, she's talking about a particular age group or
No,
herself as an adult?
no. She says that I think in general she uses a mask with a spacer, but
Oh,
we
for
do
her
also
children.
know that there is the yes.
Yes, the thing is that you know, as I said, they recommend children 3 years and up, you know, who can manage to make a seal around the mouthpiece. They can use a spacer without the mask, right? But I like the mask in all children. So I usually suggest to the parents, get a mask, you know, even if the child is 9 years old, right? Because what I find is that the child might be totally asleep and knocked out, and you know, it's a little uncooperative with baking that seal and stuff. And sometimes you can just put the thing mask over his face, make your seal, and do your spray and let him, you know, breathe it in. You understand? But in general, they can use, you know, their mouthpiece, their mouth on the mouthpiece, as opposed to, you know, using the mask necessarily.
Okay, so you want to look at these. It's from an anonymous attendee. The question, it says, is tidal breathing when using the spacer ever recommended? I'm not quite, can you understand what the person is asking?
Yes.
Okay.
Yes, I mean, you know, it's better than nothing. If you're using the mask, then you do tidal breathing. You understand? If you have a mouthpiece, you know, with the mask, then you should do it like I had indicated, you know,
Right.
before. Yeah.
Right. So how far are we along the way to investigating folklore therapies for asthma? Do we know any folklore therapies? Maybe ganja?
Well, yeah, so there are you know, certain chemicals.
I think there's rat soup too, isn't there? Yes, I think I've heard about using cane rat soup. I'm going into the depths of my my knowledge. I think there's rat soup, but no, it's not just rat. It has to be cane rat. I boil it. I make a soup and drink it.
No, I laugh because I'm freaked out with rats, you know, so when it's a rat fruit, you know. But yeah, but you know what I would recommend to, you know, individuals that, you know, if you're doing a trial of some of those things, which I'm not necessarily fully fair with, use your regular medication,
I
you know,
agree
as
with you.
priority.
In the Jamaican context, where is mold? Yeah, mold is all over, especially in the wet places. How have these managements affected asthma morbidity and mortality in our local experience?
Yeah, so, you know, of course, we're talking a lot about allergen sensitization, right? And, you know, we believe that with this increased exposure, you know, it increases sensitization. And when we talk about allergic asthma, you know, possibly the increased rates and stuff that we're seeing, you know, has a lot to do with a lot of this exposure. And just, you know, something even more critical, smoking, you know, in the home, you understand, is one of those, you know, strong indicators of future, you know, risk for wheezing.
I think even when the woman is pregnant, you know, because the baby will get chemicals from the smoke through the umbilical cord. This person was saying, regarding the statement on dietary triggers, I've heard it said that dyes in box juices are a trigger. Is that something that you have come across?
The thing with diet, so a lot of times, you know, as doctors, we kind of a little inclined to believe that diet plays a significant role, you know, in asthma triggers. But it has not been found to be that significant. It's not as common as we think, right? So food allergies as a cause for asthma is not, you know, as significant as, you know, we generally believe.
Let's move this one. Then there we have this one. Oh, I had asthma as a kid, but I grew out of it. But can one really grow out of asthma?
That's a question.
Well, I'm going to read it. It's can you talk a little about I grew out of asthma or no longer asthmatic? Could you place emphasis on importance for those who probably were diagnosed and eventually grew out of it or haven't had any triggers for years? a real life
Yeah.
story of my lecturer's cousin who had a panic attack after a nightmare and an asthma attack after, but she didn't have any inhaler or nebulizer to relieve the attack, which led to her death.
Thank you. I mean, that kind of summarize and answer the question at the same time, right? When I was preparing this presentation, I had an asthma attack, right? Because I'm asthmatic, and I found it so funny. I'm putting together the slides, and I began wheezing. I tell people all the time that when I was a child, you know, I had, you know, asthma symptoms, and I never wheezed, I won't tell you my age, until I was a big grown man. And then I had another attack, right? So we usually say you don't grow out asthma. You know, it can be controlled and that sort of thing, but always be on the alert. A pastor friend of ours had the same situation. He had an asthma attack and never treated it, you know, DPH or whatever, and he died at home, a big man, all right?
Yep. This wasn't a kid, but it was an adult. I was in the emergency department, and this nurse, her husband had an asthma attack. She just rushed him in, and when he came in, he was blue. And she said, "Doc, he just stopped breathing, and his airway had shut down. Now I can't use any oxygen. His airway is shut down. What I had to do, I had to use aminophylline. But I know there's a lot of taboo about aminophylline, but the man recovered. Trust me, the man recovered because I used the IV aminophylline, the way I was taught to do. But I know that there's a big taboo about aminophylline. But I think when you have the airway lockdown, what do you say about when a kid's airway is locked down? What do you do?
Well, you know, that's a good point, because I frequently encounter children in the office who they come in with their cough and their stuff. You listen to them, and the breath sounds are so reduced. I mean, not necessarily a silent chest, but they're so reduced that you hardly hear any wheezing. But you have to use your history, your clinical presentation, your examination findings, you know, which really not telling you that he's wheezing, and this child was getting, you know, his DPH and stuff because he's not wheezing. Because of your index of suspicion, you give the child a trial of bronchodilator, and when the child comes back to you for review, the child is wheezing like crazy. You understand? So be careful about that child with the silent chest. And
so the child with the silent chest is sending them to hospital.
Yeah, well, that's what I'm saying. It's not that the child has a silent chest, but the breath sounds are so reduced because of his bronchospasm. You give him one nebulization and he opens up, you know, so well, and subsequently he settles, you know. But yes, if you have a child with a challenge chest, that's a sick child. It's going to be critical, and that child needs to be given something while you move him, you know, to a hospital setting.
Do we have a protocol or recommendation as it pertains to ophthalmic assessment for children who are using a lot of corticosteroids?
Ophthalmic
Is there a protocol for this?
Assessment. I'm not aware of a protocol per se, but what I would say is that, you know, the new modality in managing asthma is geared towards reducing the use of this oral corticosteroids over a long period of time. Right. So, you know, if we manage our patients properly, you should be able to, you know, not use the oral corticosteroids at all, full stop. Right. You know, so that's our aim, really.
That's right. Dr. Pryce, thank you so much. There are some questions that may not have been answered. If you'd be kind enough to answer them, whichever ones have not been answered. Thank you again. Thank you. It has been, you really prepared a wonderful feast for us. Thank you so much. All right, so, all right, at this time, I invite Indus Farmer to come and tell us what they have to inform us about. I know they have a lot of things that we use in our practices. So Indus Farmer, over to you.
Good afternoon, doctor. Do you hear me?
Yes, loud and clear, and I'm seeing you too.
Yeah, great.
Welcome and Happy New Year.
Happy New Year to you all, doctor. Can I share the screen?
Go ahead, please. Over to you.
Thank you very much for AGPJ for giving opportunity for Indus. And as is the first month of the year, wish you all happy and prosperous 2024 for the presenters, moderators, as well as participants from Indus Life Sciences. We have actually a couple of products which could be recommended for pediatrics. One of the drug that we introduced in 2022 is for those children who have suffering from stomach problem, maybe gastritis or conditions like that. We have this antacid, which we actually it is as designated as a third generation antacid, classified as a third generation antacid, which has this unique ingredient on it called as alginic acid. I'm pretty sure most of you must be heard about this alginic acid. And for those who are not aware of it, this is a natural algae. This is a natural algae that helps to stop acid reflux and thereby it prevents heartburn also. So if you could see in the next slide, you could see it here, even though it's mentioned in the slide as first time in Jamaica, basically it is the first time in Caribbean. The new gel is our new antacid gel that has this alginic acid, which as you could see in the slide, this alginic acid in this antacid, when it is taken, it mixes with the stomach acid content and forms the foam called as alginate raft, as you could see in the screen. And this alginate raft floats over the stomach acid content and it prevents the acid content of the stomach from moving from stomach into the esophagus. And we all know the mucous membrane of the stomach is stronger than the mucous membrane of the esophagus. And that's why any acid content from the stomach enters into the esophagus, it causes serious burning sensation. And especially if it happens at bedtime and it's severe, some may even confuse it for heart attack. So this is the first antacid in whole Caribbean, because I had the opportunity to work in Guyana, Barbados, Cayman, Bahamas. I have not come across an antacid which has this unique alginic acid in it. And this alginic acid acts like a barrier, thereby it does not allow the acid move from stomach into the esophagus, thereby the heartburn or the acid reflux is prevented, thereby the heartburn will not be there. And to understand it better, we have a nice clip. If you see this clip, you will understand how exactly the alginic acid helps to prevent acid reflux and heartburn. As you could see here, when the person takes this antacid, it goes into the stomach. The alginic acid in the antacid interacts with the acid content of the stomach, and the foam, alginate raft, is formed. And this alginate raft stops the acid content moving from stomach into the esophagus. N number of times the acid tries to enter into esophagus, it will be prevented. And this foam is formed in just 4 minutes and it stays in the stomach literally more than 5 hours. After 5 hours, it will get excreted completely along with the acid content of the stomach and no residue is left. That's the major advantage of this. And thereby, new gel is the first antacid in whole Caribbean, is not only good for acid neutralization or to relieve gas because it has dimethicone. We all know the benefit of dimethicone. It relieves gas, burping conditions like that is recommended. And the magnesium hydroxide, aluminum hydroxide, magnesium trisilicate that you see helps to neutralize acidity. And the good news, especially for pediatricians, is that it's safe in children less than 10 years of age also, if they have any stomach, upset or stomach conditions. And if you want to recommend an antacid, you can safely recommend new gel for them. If in respect to the dose, is normally recommended 10 ml if you say 2 to 3 times a day for adult who is around 60 or 65 kg. So we can calculate it for the body weight, and then accordingly it can be recommended for pediatrics too. And it's safe in diabetes, I mean for elderly people also, as because it is sugar free, and also it's safe in pregnancy, I mean all 3 trimesters of pregnancy, first trimester, second trimester, third trimester of pregnancy, it can be recommended. And as I mentioned, safe in children. And one point I like to highlight is if you look at the screen, you will be seeing it has these acid neutralizing medications like the magnesium hydroxide, aluminum hydroxide, magnesium trisilicate. They all in uniform 250 milligram each. Why it's in uniform is that if one of them is in a higher concentration strength, then it may induce either diarrhea or constipation. If they are uniform, the incidence of diarrhea or constipation will not be there. So new gel will not induce diarrhea or constipation also in your patients who are taking this antacid. As I mentioned, the brand name itself, new gel, just to communicate, this is the new generation. Basically, it's third generation, which is the latest generation. So we just coined it new generation antacid gel, new gel. And it has a mint flavor. So the benefit we all know about mint, it has a digestive benefit also. So it helps for digestion too. And it's available as over the counter across Caribbean in all the Caribbean market. As mean English speaking Caribbean, it is available currently in all the English speaking Caribbean countries. It's available as over the counter. So we have new gel in all these market, including Jamaica, Guyana, Barbados, Cayman, Bahamas. As you could regular antacid pack size of 200 ml. We do have as 100 ml pack size. And also recently, few months ago, we introduced in single dose sachet, which is 10 ml sachets that we introduced it. So that is actually the dose for adults. 10 ml is normally taken for adults. So it's available. We call as on the go sachets, which is very convenient for those who are working or traveling or whatever it is, or visiting restaurants. The 10 ml sachet is a liquid sachet. So the benefit, they don't have to mix with water. They can just stir it and squeeze it like a jelly in the mouth. That is also available as sachet. So we are the first company has introduced in 3 different pack sizes, 200, 100, and on the go 10 ml sachets are there for new gel. And for pediatrics, we have this cefuroxime Intil, and we know it's recommended in all this respiratory infection, upper and lower respiratory infection, in skin infection and other conditions. The highlighting point about this brand Intil, that's cefuroxime for doctors who want to understand why we coined a brand name like Intil for cefuroxime is very simple. The company name is Indus. We took in from Indus, and the active drug is cefuroxime. So Indus cefuroxime Intil. That's how we coined it. And this is the first brand in whole Caribbean has been introduced as fruit punch flavor. The cefuroxime is available as fruit punch flavor. So we know one of the challenge with this antibiotic cefuroxime, the drug is highly bitter, and especially when you recommend it to pediatrics, many a times, most of the times rather, they will spit it or throw it because of the bitterness of the drug. So we masked it with the fruit punch flavor. In fact, fruit punch is a specific flavor for Caribbean countries, and we masked it fruit punch flavor. I've been getting good positive review from Pediatrician Bustamante also, that the kids found it more palatable compared to, I'm not bashing any brand by the way, other brands, the Intil found to be more palatable. So it's available as 125 milligram per 5 ml. It's a 70 ml pack. Another good news in Jamaica, it's in the win list in the NHF. So doctors working in the hospital, public sector, if you recommend it, the patients will get in the respective pharmacies in the hospital, they'll get it Intil. So that's our Intil suspension. Of course, we have 500 milligram tablets for adults. So this is Intil. We know about the dosage, and cost is very affordable. And doctor, I just want to refresh you one of our cough productive cough, which is our Viscough, specifically recommended for bronchitis, COPD, asthmatic conditions, because today the topic is more about asthmatic. And we have a preparation which offers 3 active drugs on it, which has ambroxol, which is a mucolytic drug which breaks down the mucus, ambroxol, and it has salbutamol, the bronchodilator, and the guaifenesin expectorant. And this is recommended 2 years and above is ideal for Viscough, and they work in synergy. The 3 active drugs you see, they work in synergy. The role of ambroxol is to break down the mucus. Salbutamol helps to open the airways. and guaifenesin helps to expel the sputum. So break, open, expel. So it works in synergy, break, open, expel. So the ambroxyl, most other cough syrups, some of them I've seen they use bromaxin as a mucolytic agent. Here we have ambroxyl. The benefit of ambroxyl is that ambroxyl is site-specific in action, means it binds to the mucus of the lungs. Unlike bromaxin, which also binds with the mucus of the lungs, but unfortunately, bromaxin has affinity for the mucus of the stomach also. Whereas ambroxyl is specific in action, it binds with the mucus of the lungs, it breaks the mucus. And it has salbutamol and guaifenesin also. And it has 2 milligrams salbutamol 5 ml. So that is Viscoff, yes, is available. For vicious, viscous cough, Viscoff. Yes, is salbutamol. And last but not the least, I want to conclude my presentation with the big juice. We always address it as that AminoPep. I'm pretty sure all doctors must be familiar with this brand. This is ideal for any age group, especially for children. It's very, very good. Especially 18 months and above, it is recommended. The benefit of AminoPep in children basically is that the lysine is promotes growth and appetite in children, and it has zinc. 50 milligrams zinc is there. We all know it boosts the immunity, especially children's are more vulnerable for immunity. They get compromised on that. So when you recommend zinc, which is there in AminoPep, it boosts the immunity. It has vitamin C, which is good for cold and flu. It has calcium, and also has the phenylalanine is one of the amino acids which is very good for growing face, especially for kids. It's one of the amino acids found to be useful to promote concentration and memory. So we all know, no, that today the kids has more challenge than the adults with respect to education, as well as in play, whatever they play, whether chess or anything. So, or spelling bee or those quiz programs, anything, the phenylalanine can promote concentration memory for them. And arginine is good for healing. That's histidine is for hemoglobin, and tryptophan is for stress buster amino acid, we call it as. Like each of the amino acid has a role to play, and this is the first supplement in whole Caribbean offers all amino acids in in a formula like this AminoPep. And these amino acids essential for many hormones like hair, nail, skin, everything. And it has whole range of vitamins B1, B2, B6, B12, vitamin E, vitamin C, vitamin D. You could see everything in the screen. This is the composition of AminoPep, and is recommended for children 18 months and above. Less than 18 months, mother's milk is the best. And above 18 months, you can start recommending AminoPep, and it can be recommended for adults also. And during pregnancy phase, during lactation phase, it can be recommended. And the dose for children normally 5 ml is sufficient. Adults is normally 10 ml, but somebody is immunocompromised on those persons, or undergoing chemotherapy, you can step up the dose up to 15 mils. So, and it's a chocolate caramel flavor, so I'm pretty sure kids will love it. And I have seen across some pediatricians has told me that even for children, they use it as a pancake syrup. Instead of pancake syrup, they use AminoPep as a substitute to the pancake syrup and put it on the pancake, so kids will enjoy eating it. Okay, so it can be mixed with cold milk or juice also, and it is sweet but no natural sugar on it. Sugar substitute sorbitol is there. So that's our AminoPep, and we coined the brand name. It gives a pep to the step. And to conclude, we all know the most important, WHO recommendations also. The important tips for healthy lifestyle is exercise of 30 minutes a day of brisk walking, and nutritious food like fruits and vegetables in our diet, and adequate water, and sleep for 6 to 7 hours a day, all these things. But we thought we should also include one more. That's our AminoPep to conclude your day so that you make your day good. That's our AminoPep, gives pep to your step. Thank you very much, doctor. Thank you all.
Thank you so much. Indus Farmer, you really brought new gel, Intel, Viscoff S, AminoPep. And thank you so much for even bringing in about lifestyle,
Thank you very
how
much,
important
Doctor.
the lifestyle is, and then you add AminoPep to that for different lifestyle stages. Thank you so much. You've
Thank
been a wonderful support to the association through the years. At this time, I invite GlaxoSmithKline to come on board and share with us your products.
Hi, good day. My name is Salvatore Ferraro. I'm a pediatrician and infectologist. And I work at GSK as a medical manager in the anti-infective area. I would like to start this presentation with a very interesting information about the role that GSK has played in the development of antibiotics. So as we know, the modern age of antibiotic discovery did not begin until the early 1900s and featured scientists such as Alexander Fleming, Paul Ehrlich, Selman Wassman, and others. They, along with the medicine that they discovered, became famous and were acknowledged at the highest level, receiving Nobel Awards. Perhaps not so widely recognized was the role that GSK company initially Beecham Research Laboratory and Glaxo Laboratory in the development of penicillin and cephalosporin, including a range of semi-synthetic antibiotics, many of which still play an important role in treating infection worldwide today. So in the 1960s, after discovering the penicillin ring, Beecham Research Laboratory launched methicillin. That was the first anti-staphylococcal penicillin. And a little later, ampicillin, that is a penicillin which with a broader spectrum than penicillin. Then came carbanicillin, the first antibiotic with activity against Pseudomonas. And finally, at the end of the 1960s, was developed amoxicillin, which maintained the same spectrum of ampicillin, but had a better oral bioavailability. The bacteria obviously did not take long to generate resistance, and then Beecham Research Laboratory discovered clavulanic acid from a fungus. Clavulanic acid is a very potent beta-lactamase inhibitor. Beta-lactamase, by the hand, are a mechanism of resistance that is characterized by hydrolysing beta-lactams. After that, in the early 1980s, Beecham Research Laboratory launched Augmentin in UK. Combination of amoxicillin plus clavulanic acid that rescue the spectrum of amoxicillin and expand its activity against these beta-lactamase producing bacteria. This discovery and the development of clavulanic wins Beecham Research Laboratory the Queen's Award for Technological Achievement. Augmentin still indicate for short-term treatment of bacterial infection, such as upper and lower respiratory tract infections, skin and soft tissues infection, and genitourinary infections when caused by amoxicillin clavulanic susceptible organism. All these indications are supported by important guidelines such as the American Academy of Pediatrics in its guidelines, the WHO Essential Medical List, the British Thoracic Society, the American Thoracic Society, and others. On the other hand, amoxicillin clavulanic acid has been included as an access group antibiotic. WHO model list of essential medicine has been updated every 2 years since 1977. And the aim of this category of this classification is to assist in antibiotic stewardship at local, national, and global level and to reduce antimicrobial resistance. 3 different categories have been developed by WHO, and antibiotics such as macrolides, cephalosporin, quinolones have been included in the watch group category, while amoxiclav was included in the access group. I would like to highlight that that the clavulanic acid, which is the key component that increases the effectiveness of amoxicillin on beta-lactamase producing bacteria, is characterized by being an agent with significant enzymatic instability. It is known to be unstable at high temperature and pH, as well as being hygroscopic. That is, it absorbs water from the surrounding humidity. So it's necessary to maintain a relative humidity lower than 30% in order to avoid degradation and therefore loss of effectiveness. In the case of fermenting of all GSK clavulanic acid is produced in a single factory in the UK under rigorous standard that guarantee the highest quality and in this important compound. And over the final product, GSK performed more than 300 stability tests according to established protocol and are monitored by more than 140 experts. Just as I mentioned that 40 years ago, Mentin won the Queen's Award for Technological Achievement. Last year, Mentin was recognized at the 2022 Pryce Gallean Golden Jubilee Award in the Best Pharmaceutical Product category with a bronze medal. Gallean Golden was Pryce Gallean was founded in France 50 years ago by a pharmacist, Roland Mel, in honor of Gallen. Gallen was the father of medical science and the mother of pharmacology. And this Pryce support, recognize, and awards the effort of scientists, research, and companies that are committed to advancing medical innovation with the power to change human conditions. So winning the award, Pryce Gallean is considered to be a significant achievement for any pharmaceutical product. This is the literature that supports the information presented, and for any adverse event reporting or product complaint, please contact us by email or telephone. Thanks very much for your attention.
Thank you so much, GlaxoSmithKline. At this time, you're in for a wonderful treat because coming up next is Professor Celia D.C. Christie. She is an amazing lady, and I want to tell you a little about her. Celia D.C. Christie Samuels is Professor of Pediatrics at the University of the West Indies, Consultant Pediatrician at the University Hospital of the West Indies, Jamaica, since 1999, and Professor Emerita since 2022. This was preceded by assistant and associate professorships in pediatrics at the University of Cincinnati and also consultant pediatrician, infectious diseases specialist, and infection control officer at the Cincinnati Children's Hospital Research Foundation, USA. She completed her MBBS and DM Pediatrics degrees at the UWI, Pediatric Infectious Disease Fellowships at the Yale University School of Medicine, and an MPH degree from Johns Hopkins University, USA. She's involved in clinical care, teaching, research, advocacy, and outreach. Her research included clinical trials of vaccines, epidemics of emerging infectious diseases like drug-resistant pneumococcus, pertussis, rotavirus, HIV, AIDS, Zika, chikungunya, dengue, COVID-19, and molecular epidemiology, leading to over 130 publications, including 2 in the prestigious New England Journal of Medicine. Her awards included the Elizabeth Glaser Pediatric AIDS Foundation International Leader Award, 2002, Infectious Diseases Society of America Service Award, as chair of the Committee on Professional Development and Equity in 2002, Excellence in Science Stephen Prieblood Award from the National Immunization Program, Centers for Disease Control and Prevention USA 2002. Lancet's Paper of the Year Award for the Best Original International Research Publication as a co-author on the rotavirus efficacy and safety trial in 2006. The Vice Chancellor's Award for the Research Excellence in 2008, Caribbean Public Health Association Award for Excellence in Caribbean Health Research in 2013, the Institute of Jamaica's Gold Musgrave Medal for Distinguished Eminence in Science 2014, Commander of the Order of Distinction 2018, the Paediatric Association of Jamaica's Distinguished Honoree in 2023, the UWI's Principals Award for Research Excellence for over 10 times, including for COVID-19 in 2023, and UWI's Medical and Alumni Association's Pelican Award for Eminence in Leadership, Academic Medicine and Research in Child and Public Health in 2023. Apart from all of these academics, she enjoys interacting with her daughter Celia and her family members and playing her clarinet. Please help me to welcome this giant, Professor Celia Christie, who will speak to us on upper and lower respiratory tract infections in the pediatric population. Professor Christie, I invite you to take over. Thank you.
Good afternoon, distinguished colleagues and friends. It is indeed my pleasure, my privilege, and my honor to accept this invitation so kindly extended for me to speak to upper and lower respiratory tract infections in children in the context of the COVID-19 pandemic. And I thank Dr. Buckner very, very much for your very kind and generous introduction. Okay. So the background and purpose for today's talk is that I'll speak to the current upper and lower respiratory tract infections as this relates to the COVID-19 pandemic before, during, and after. I'll speak in detail to SARS-CoV-2, COVID-19 epidemiology. I'll speak to COVID-19 RSV and influenza vaccines, mucosal vaccines, children and SARS-CoV-2 and how they present as it relates to their respiratory presentations, MIS-C and long COVID, lockdowns and non-pharmaceutical interventions as implemented by the WHO, the pandemic immunity gap that resulted. And then I'll speak to the various infections that are now circulating or have been circulating since. These are the current respiratory infections, particularly in children, SARS-CoV-2, RSV, influenza, group A strep, measles, bordetella pertussis, mycoplasma pneumoniae, streptococcus pneumoniae, adenoviruses, parainfluenza viruses, human metapneumoviruses, and maybe a few others. I speak to specific syndromes that relate to respiratory infections in children, and these may include pharyngitis, rhinos, sinusitis, acute otitis media, laryngotracheal bronchitis or croup, epiglottitis, bacterial tracheitis, pneumonia, empyema, lung abscesses. And then as close with a few words on prevention. Now, COVID-19 is a disease that was caused by SARS-CoV-2, which heralds its toll in the world, in the Caribbean, and in Jamaica. Globally, reports to the WHO have been grossly underestimated. We know that over 774 million confirmed cases were reported to the WHO, and of these, over 4.6 million were reported from the Caribbean. We have had over 7 million deaths, over 37,000 of which were reported from the Caribbean. There has been community spread of this virus and this disease, with many, many waves going on in several communities around the world. In the meantime, we have given over 13 billion vaccine doses of SARS-CoV-2 vaccine, but primarily this was done in the high-income countries. And here in the Caribbean, we have given over 25.5 million vaccine doses. CARPHA has reported that the range of uptake for these vaccines for one dose is 3% in Haiti, 25.4% in Jamaica for about 1.5 million doses, to 96.1% in Cayman doses per capita. Now, WHO has recently announced on the 5th of May 2023 that COVID-19 is now established and is now ongoing in various communities around the world, and it's no longer an established public health emergency of international concern, and therefore several of the guidelines and several of the interventions have been thereby lifted. Now, we have learned over the years that SARS-CoV-2 creates variants of concern. These variants of concern actually result from the fact that these viruses mutate, and they mutate constantly, such that they become more transmissible, they have increased virulence, decreased effectiveness of public health measures, and decreased responsiveness to vaccines and to monoclonal antibodies. To date, the WHO has reported 5 variants of concern. The most recent one is the Omicron variant in red, which was designated by the WHO since November 2021. It has several mutations on the spike protein and on the receptor binding protein domain of the virus, and has gone through phenotypic and viral changes several times since it was first described in November 2021, such that the current variant that is now circulating is the JN1 or the BA28611 variant. It's an Omicron subvariant, and it's now surging internationally around the world. Tracking it in the United States, it presented itself there first in September 23, and it now, as of today, represents over 86% of USA's strains that are circulating there. We know now that over 4 million visitors from the United States and other parts of the world came to Jamaica in 2023. So we know, therefore, that SARS-CoV-2 JN1 is most likely circulating here too. It is more transmissible than previous variants. There is waning immunity from natural immunity and vaccine immunity. There's a shorter incubation period for this one, going down as low as 2 to 3 days. It has the same symptoms as the preceding variants, but this time there is more diarrhea, especially in the first 3 days of the illness. It also causes increased hospitalizations, increased deaths, and where this is studied in wastewater or in sewage water, we are finding all over the world that the levels are increased. Now, looking at influenza, RSV, and SARS-CoV-2, which causes COVID-19, and these are the 3 viruses that are mostly circulating now. We know that these are mucosal respiratory viruses, which multiply primarily in the respiratory tract. So for influenza, for them, all 3 cause significant morbidity and mortality, we know, and we know that influenza has caused up to 6 million deaths per year. Influenza vaccines that we know of reduce severe illness, hospitalizations, and deaths. but vaccine efficacy is relatively low, just 14 to 16%, 60% for the last 15 seasons that we have been tracking. Vaccine immunity for influenza lasts only months, and this is offered to our high-risk persons in our communities, including our children. We know and we are grateful for the SARS-CoV-2 vaccines that have been released, because this has saved lives and saved hospitalizations. But we also know from our personal experience that there has been emergence of variant strains. Several of us have had recurrent infections, despite the fact that we have upheld to vaccine guidelines. And some of us have had natural immunity, and so we have hybrid immunity. And this also reminds us that SARS-CoV-2 vaccines are deficient. It's similar to the current influenza vaccines that we give annually. Influenza and SARS-CoV-2 vaccines are therefore similar in providing incomplete and short-lived protection against the evolving virus variants that escape population immunity. So, unlike the systemic respiratory viruses to which we are normally accustomed, that is like measles, mumps, rubella, varicella, the locally replicating SARS-CoV-2, RSV, and influenza respiratory tract infections have shorter incubation periods, rapid replication in the respiratory tract without causing systemic viremia. They do not encounter the systemic immune system to elicit systemic immune response. They cause transmission to others. They cause repeated infections over a lifetime. And we know that there is multiple mutations and antigens that are occurring all the time. So with SARS-CoV-2, the spike protein, the mutations, and there's antigenic drift with influenza. It's therefore difficult to make universal vaccines which will uphold. This partially explains why current vaccines delivered systemically have been ineffective in providing long-term control for immunity for these mucosal respiratory viruses, meaning SARS-CoV-2, RSV, and influenza. Furthermore, these natural infections, when they occur with these mucosal viruses, are tolerated, very well tolerated by the immune system. And therefore, it is felt that secretory mucosal immunity in the respiratory tract would generally be more effective than the systemic immunity in controlling these viruses. So, mucosal vaccines then would be optimal for these mucosal respiratory infections for SARS-CoV-2, RSV, and influenza. There are several issues that need to be considered. But in general, we have to conclude that there have been unsuccessful attempts to date to elicit solid protection against the mucosal respiratory viruses and to control the deadly outbreaks and pandemics that these three viruses concern. And this is probably a scientific and public health failure that must be urgently addressed. And therefore, we are happy that there are many investigators and collaborative groups around the world that are rethinking from the ground up and forging new pathways to develop mucosal vaccines that are given right to the respiratory tract rather than giving them IM as has been done. And this is a paper that comes from Dr. Tony Fauci, who, as you know, is the father of COVID-19. So in the United States, there they give booster doses of vaccines starting at 2 months of age, 3 doses to children, and then they give an annual booster to children, a monovalent booster with now the Omicron vaccine. And then for older persons, less than 5 through adulthood, who have received the primary vaccination set, then they get annual boosters with this monovalent Omicron booster for the last 2 seasons or so. In Jamaica, we have had, most of us have had 2 or 3 doses of the vaccines, various vaccines in persons 18 years and older. And for children, we offered them, those who were older than 12 years of age, they were offered the first or second dose of the Pfizer vaccine. Our pediatricians, you'll remember, were very, very concerned about the complications, the cardiac complications that were happening in our young people, and therefore we did not support it for giving to children who were younger than 12 years of age. Now, let's speak a little bit now about COVID-19 in children, remembering now that the JA1 variant is now circulating. Children represent over 18% of cases of COVID in the United States since the COVID-19 pandemic began. 50% of these cases are asymptomatic. However, some children are symptomatic and may even need to be hospitalized and even be placed on a ventilator. The most at-risk subsets of children include those who have chronic lung disease, neurological disorders, cardiovascular disease and prematurity, obesity, and a number of other at-risk factors. When the respiratory findings occur, this is associated with fever, an initial cough that later on becomes productive, chest pain, which is usually pleuritic, new nasal congestion and sinusitis, sore throat and pharyngitis. And this occurs against a background of other symptoms, including loss of taste or smell, skin changes, nausea, vomiting and diarrhea, chills, muscle aches and pain, fatigue, and new severe headache. Looking at the respiratory infections in more detail in children, COVID-19 occurs, we know, in all age groups, and this predominates in school-age children and adolescents. Exposures occur in family clusters, in schools, but in truth, it's really more than that, because essentially most persons are not tested, and certainly they're not being tested now. The incubation period, as I said before, can be short with the JN1 variant, but can extend up to 14 days. In the first phase, SARS-CoV-2 binds to the epithelial cells of the respiratory tract and produces mild disease. In phase 2, it migrates down the airways and enters the alveolar epithelial cells, facilitating pulmonary viral replication and localized inflammation, leading to pneumonia. And then in phase 3, you get the cytokine storm with pulmonary edema and moderate to severe disease. Those children who go on to develop pneumonia or acute respiratory distress syndrome, that's the 2% of them, will present with fever and cough in about 50% and shortness of breath in about 4% as preceding signs and symptoms. The risks will include those who are less than a month of age, male sex, and those who progress with lower airways infectious comorbidities, compromise, and the comorbidities as I mentioned before. The chest X-ray will show peribronchial coughing, ground glass opacities, consolidation in the lung, pleural effusions, and mediastinal widening. CT scans, like the chest X-rays, will be similar, and then you'll have cavitary disease and some nodules. Laboratory findings will include the presence of SARS-CoV-2, a low white blood cell count, low neutrophils, high ferritins, high CRPs, and a high procalcitonins. We manage these children, those who are very ill, by hospitalizing them, giving them respiratory support with oxygen, ventilation, antibiotics for community-acquired infections, which would be pneumococcus in particular, and group A strep, and maybe even Staph aureus, and also hospital-acquired infections based on what's happening of the epidemiology of these bacterial infections in the various hospitals. We also support them with fluid and electrolytes, laboratory monitoring, and follow-up. With this kind of treatment and care, the mortality is less than 2.5%. So here we have a 10-year-old boy who presented with fever, cough, and shortness of breath. And you'll see in panel A, of his chest X-ray, where he has ground glass opacities in both lungs and consolidations in the left inferior lobe. There's also a retrocardiac density and loss of the silhouette of the diaphragm, particularly so on the left side. Then in the second panel, you see he has diffuse bilateral coalescent consolidations which preceded the fact that he developed acute respiratory distress syndrome. And 24 hours later, you will see that there is massive bilateral consolidation with consolidation in both lung fields. And 8 days later, after the appropriate management, the lung injury has more or less significantly resolved. So he did well. Here we have a 13-year-old boy with COVID-19 pneumonia presenting with fever, shortness of breath, and chest pain. And you'll see his chest CT and showing that he has multiple peripheral and central bilateral pulmonary ground glass opacities in both lung fields. This is a chest CT scan of a 2-year-old with COVID-19 pneumonia, another age group. And this child has nodular, patchy ground glass opacities and consolidation with blurry margins in both lung fields. There's also mid-inner zones. It also involves the mid-inner zones of both lower lungs. And then you also have high-density lesions in the periphery showing a halo appearance, which is shown here. And then you also have ground glass opacities in the left lower zone, as shown here, upper lobe, as shown here. Respiratory management will include oxygen therapy through the low flow system for mild hypoxia, high flow system oxygen in those who have moderate to severe hypoxia. For those who need invasive mechanical ventilation, if there is respiratory failure or persistent hypoxia, we go on to, these will need increased oxygen, or those who have worsening tachypnea in a patient who is on high flow nasal oxygen. And these go on, we give them protective mechanical ventilation. The ventilator settings are set here. You have the tidal volume of 4 to 8 mils per kil, various respiratory rates based on the age of the child, an IE ratio of 1 to 2 a PEEP, according to the oxygenation, arterial blood gases, and chest X-ray findings. And we start with an FiO2 of 100% and reduce it to 60% in 2 to 6 hours. Respiratory management, we should nurse these children in the prone position, especially those who have moderate to severe ARDS who need oxygen therapy or mechanical ventilation. Glucocorticoids are available in various doses as it relates to prednisolone, dexamethasone, methylprednisolone, and hydrocortisone. And we also follow up these children as it relates to monitoring their vital signs, signals for respiratory worsening, and adjust these as needed. And then we give empiric antibiotics for community-acquired infections or nosocomial infections, and we'll talk more about that later, and give special attention to patients with chronic respiratory conditions. These include asthma and those who have BPD. Now, COVID-19 in children, we have moderate to severe complications, as I mentioned before, acute respiratory distress syndrome. We also can have myocarditis and acute renal failure and multisystem organ failure. In children, we have been seeing the multisystem inflammatory syndrome, or MIS-C, and this sort of presents also as like Kawasaki disease and also like toxic shock syndrome. And we are also now seeing pediatric long COVID. We see here a child, the pictures are here, and you see a child here who had a rupture of the coronary aneurysms with bleeding, as you can see. And then you see features related to MIS-C and Kawasaki disease, the rash in the hands, the strawberry tongue, and the skin rash. Multisystem inflammatory syndrome has been identified right across the world, and there are several definitions, but in general, they all speak to the fact that there is laboratory inflammation and evidence of clinically severe illness requiring hospitalization with multisystem involvement of 2 or more organs. And you'll see among the organs, the respiratory system is very much included. These children should have no alternative plausible diagnosis. They should have evidence of positive for current or recent SARS-CoV-2 infection by laboratory test or exposure to a suspected or confirmed case within the 4 weeks prior. And of course, if COVID is circulating in the community, then we know that the child may, of course, have been exposed. There is to be fever, which should be lasting more than 24 hours, and there should be evidence of inflammation with inflammatory markers as shown, including the elevated CRP. There should also, if there is evidence of full or partial criteria for Kawasaki disease or any child who dies from a SARS-CoV-2 infection, this is also Miss C. These were recently revised in February 2023 to be simplified. Now, when we look at Miss C cases that were reported in the largest number of cases, from 123 papers that were published for a population of 4,475 Miss C cases internationally, you will see here that 91% of the children had fever for more than 4 days. Gastrointestinal symptoms and rash were prevalent in over 50%. The respiratory system was very much represented in over 42% of cases, and almost 40% of the children presented in shock, and there was myocarditis, neurological symptoms, and Kawasaki disease for 30% of cases. The C-reactive protein was present for 93% of cases, but still there were other inflammatory markers that were high, the D-dimers, there was high troponins, and high ferritins and high ESR in a huge subset, and the echo was abnormal as well. In these studies as well, you'll see here that 17% of the children needed mechanical ventilation, but the treatment modalities including antivirals, which would have been remdesivir for SARS-CoV-2, and this is not necessarily available in right across the world. And indeed, where it is even available, the pediatricians were a little bit reluctant, certainly at the university hospital, to use it. Antibiotics were given in 33%, inotropes in 38%, anticoagulation in 48%, steroids in 55%. 65% of the children were admitted to the ICU. 70% of them got IVIG, 2.4% of them died, and 95% of them recovered, and that's really good. At the University Hospital of the West Indies, we also had our experience in children who were less than 16 years of age. And in the first 15 months of the pandemic, we saw 79 children at the university, of which 41 of them were admitted. And among those who were admitted, 18 of them had Miss C and 23 of them did not have Miss C when we evaluated them. And this was a study that was very much supported in funding by the CDC. Essentially, you will see here the wide variety of symptoms that they had: fever, fatigue and lethargy, lymphadenopathy, and more than 2 organ systems involved, including gastrointestinal, hematologic, coagulopathic, dermatologic. They had mucositis, they had Kawasaki's disease. Pleural effusions were seen in up to 17% of the children who were admitted to hospital. The comorbidities that we saw was in a third here at the university, and these children had sickle cell disease, asthma, they were obese, or they had cancer. Kawasaki syndrome was seen in 44%. The inflammatory markers are shown. And we treated ours with IV IgG, 78%. Aspirin was given in 68%, steroids in 50%, and 11% of them had non-invasive ventilation. But none of our children were in shock that they needed inotropes or vasopressor support. The Miss C negative cases who were admitted received standard of care. There was one child who died who had underlying sickle cell disease, chronic renal disease and was getting renal replacement therapy with dialysis. And this child also had myocardial ischemia. 5% of the children were readmitted, and 95% of them went on to have full recovery and discharge from hospital. But we are now concerned about long COVID, which is in children. And this is defined by the WHO as confirmed or probable SARS-CoV-2 infection with symptoms lasting over 2 months, which initially occurred within 3 months of the acute COVID-19 infection. And of these features, there are fatigue, altered smell, anosmia, and anxiety. And these are the most common, along with 23 other symptoms that some of these are shown here. The children will present with chest pain, cough, dyspnea, sore throat, and respiratory symptoms, and fever, persistent fever, as it relates to the respiratory symptoms as shown by the table. These symptoms may be new of onset or persistent from the initial illness. They may fluctuate or relapse over time, and this, of course, applies to children of all age groups. Now, let's talk a little bit about lockdowns and the pandemic immunity gap that occurred. Now, we know that when the epidemic occurred, the WHO implemented certain behavioral changes that we had to adapt, whether personally or as a country. And these included the non-pharmaceutical interventions, which included hand hygiene, which was extensive, mask wearing, social distancing, and the isolation of sick individuals. In addition, we know that our schools and daycare centers were closed. We had lockdowns, parties and various gatherings were canceled, and travel was restricted. What this meant is that these non-pharmaceutical interventions created fewer circulating respiratory infections while the COVID-19 strict measures were implemented. This therefore created what we call an immunity gap. And the immunity gap is a group of susceptible persons who avoided pharyngeal colonization and subsequent infection with the normal little respiratory viral pathogens to which we normally are accustomed to. It therefore means that we had children who lacked pathogen-specific immunity, and therefore they had no immune protection against future endemic viral infections. Added to this insult was the fact that there were lagging vaccine rates in various communities during the lockdowns, and this widened this immunity gap. So the children were also now at risk for vaccine preventable infections. The surges of infections with these relaxed lockdowns and in children, taking the children, when the infection surged when the lockdowns were relaxed and the children returned to the community, returned to daycare centers, returned to schools, returned to their normal play activities. And so what we are seeing now is that the lockdowns and the pandemic immunity gap is therefore partly to blame for the surging respiratory infections which we are now seeing, which include influenza virus, RSV, group A streptococcus, and a number of other pathogens which we will now talk about. So I'm going to now look at a few countries. So in the UK, you will see the indirect effects of the lockdown on the hospitalizations for 19 infectious diseases using data that was put together by the UK's National Health Service during 2017, which preceded to 2020, which preceded the epidemic, going into 2020 and 2021. And you'll see here that of these 19 diseases, 18 of them were seen less, except for acute pyelonephritis. And this influenced also a sustained reduction of respiratory tract infections in children, such that bronchiolitis fell by 82%, influenza hospitalizations fell by 94%, croup LTB hospitalizations fell by 78%, upper respiratory infections and tonsillitis fell by 66%, pneumonia hospitalizations by 60%, measles hospitalizations fell by 90%, and so were deaths. Looking at RSV infections in a hospital in Shanghai, you will see before the epidemic, there were seasonal surges of RSV as would normally occur. During the pandemic and the lockdown that occurred in China, RSV more or less went away. And then once the community was reopened, you had positive RSV circulating again, and the numbers of cases went up, as did the RSV positivity rate. Looking at mainland China now, through 2023, 2018 to 2023, you'll see here again, and this now I think has to do with influenza. I'm not seeing the titles very well, but this has to do with influenza H1N1 and influenza H3N2. And before the epidemic, you'll see the normal seasonal surge. And then during the epidemic in gray, influenza literally went away. And once the pandemic, non-pharmaceutical interventions were lifted, you will see that influenza came back with a vengeance. And essentially, since about September last year, there have been respiratory infections that are occurring in China in huge numbers. Thousands and thousands and thousands of children are being seen in their ambulatory services and in their hospital services. And so the WHO has been involved in this, and they have been monitoring these undiagnosed pneumonias and severe acute respiratory infections, which have been overwhelming these pediatric services. Essentially, the coin that they're now tossing around is that these children have white lung pneumonia, which essentially is saying that your chest x-ray goes from black, where you have the lungs completely being aerated, to white, where there is no pneumonic consolidation, whether it be from a virus or from a bacterial pathogen. And what they have been seeing there is primarily influenza infections, influenza A and B, RSV infections, mycoplasma pneumonia infections, SARS-CoV-2 infections, adenovirus infections, and several other known severe acute respiratory infectious pathogens. And this again has been attributed to the lifting of the non-pharmaceutical interventions that were implemented in China. And you remember in China, those patients were locked away completely from indoors for prolonged periods. And this, of course, created an immunity gap, particularly for the children. And so what the WHO has recommended is, and what they're doing is overseeing the surveillance for acute, serious acute respiratory infections in China. And they have recommended that vaccines be implemented there for influenza, COVID-19, and other respiratory pathogens as appropriate, and also infection control parameters. So that's UK and China. But if you look, you'll see the same thing has been happening in the United States, where the COVID-19 pandemic, pre-pandemic, you saw where in Seattle, where there is an ongoing surveillance, influenza A and B peaks were up before the pandemic. Once the pandemic lockdowns were implemented in fall, you essentially had no influenza activity. And then you had slight influenza A activity, but not influenza B in 2022, when we relaxed the non-pharmaceutical interventions. Other respiratory viruses, in fact, 9 other respiratory viruses are shown. And this is the same thing. where pre-pandemic, these viruses peaked, and then during the lockdowns, the reported viruses, number of viruses were reduced. And once you relaxed, then it increased. And this is shown for SARS-CoV-2, RSV, parainfluenza viruses, the adenoviruses, human metapneumoviruses, and also the Boca viruses. So in the United States, when the RSV surged, what was the reason for this upsurge? And essentially what the CDC did is they looked at the phylogenetic analysis to look for the reason for this surge. And looking at 77 strains, you will see that 91% of them were RSV-A and 9% of them were RSV-B. And what we're saying is that there was not a new highly virulent RSV strain that was occurring to explain the reason for the upsurge of RSV in the United States. And then there have been bacterial infections that have increased in the United States. Pediatric invasive group A strep infections in particular were now being seen along with RSV and influenza in 2 different parts of the United States, in Colorado and Minnesota. So after the historic declines in invasive bacterial infections during 2020, you see that they fell here. So you had this is what was happening before, and this is what happened during your non-pharmaceutical inventions. What happens is that you had a resurgence of invasive group A streptococcal infections as shown here. And this was seen amidst the RSV and influenza outbreaks in the United States, where there were upper respiratory tract infections in these children in 62% of them, which were occurring in the 2 weeks prior. 18% of these children had increasing sore throat. 44% of them had viral co-pathogens isolated. And these included RSV for 18%, influenza A/B 18%, and SARS-CoV-2 for 9%. And believe it or not, this was occurring on the background of stockouts of amoxicillin in the United States during the pandemic. And pertussis, or whooping cough, has also resurged in the United States, as shown here. They're seeing recent outbreaks in not only in Suffolk County in the United States, with 108 cases reported in 2023, and 100 of them were reported since the end of November. But they're also seeing this in other parts of the United States. And what is happening there is that there is waning immunity from the acellular pertussis vaccines after 3 years. So what happens is that you have asymptomatic carriers, and this is being shown not only in the United States, but in the United Kingdom, Spain, Canada, Australia, and Ireland, who switched from wholesale to acellular pertussis vaccines. What they're doing in those countries is they're using boosters in the adolescents and in the elderly. Now, acellular vaccines being used in the United States are known to stimulate the Th2 immune response and secretion of antibodies in the bloodstream. And again, this doesn't make sense because Bordetella pertussis replicates in the nose, whereas the wholesale vaccines now being used in Jamaica stimulate the Th17 immune response, triggering T cells to fight infections on the mucosal surfaces of the nose, therefore blocking circulation, entry and circulation of Bordetella pertussis into the body. And then we have to talk about measles. And the epidemic of measles is global. And what has happened is that over 61 million doses of measles-containing vaccine were postponed or missed due to COVID-19 related delays in immunization activities around the world. And therefore, because of that, there have been increased the risk of bigger outbreaks around the world and in several countries in the United States. Case in point, a recent epidemic of 85 cases in Ohio, mainly in unimmunized children. In Jamaica in 2021, up to 2021, MMR vaccine 1 was coverage approached 88% and MMR 2, 85%. I can't say what has been happening since the pandemic. So let's talk now a little bit about RSV. Now, RSV has a global incidence of over 33 million cases in children who are less than 5 years of age. 1 to 5% of these require hospital admission, and up to 200,000 of these children will die from this disease. This affects all children by the time they are 2 years of age, and the primary respiratory presentation is with upper respiratory tract infections, bronchiolitis, and lower respiratory tract infections in 25% of cases. You will see that these children present with rhinorrhea, cough, tachypnea, wheezing, creps in the chest, intercostal and subcostal retractions, grunting, nasal flaring, and this may occur with or without fever. The children also have lethargy, irritability, poor feeding, minimal respiratory effort, and apnea is observed in the preterm infants. The risks are highest in preterm infants who have chronic lung disease with bronchopulmonary dysplasia, or those who have immunodeficiency, or those who have neurological or neuromuscular conditions which prevent them from breathing in and out in the way that they should. It is treated with hydration, oxygen by nasal CPAP, bronchodilators. In some cases, they give RSV immune globulins, antibiotics for secondary bacterial infections, and antivirals where available. And this is aerosolized ribavirin. It is prevented in first world countries by palivizumab, which is a humanized monoclonal antibody, and it's given monthly in high-risk children just before the RSV season. And in the last year or so, 2 vaccines have become available in the United States, and these are given to adults and also to pregnant women in the 3rd trimester to prevent the little ones when they are born. And you can see here in these x-rays some of the findings that you'll see in patients who have RSV. So, okay. Influenza, we know, as we said before, is the most common of the infectious diseases, and it presents in children with fever, non-productive cough, chills, rigors, myalgia, headache, malaise, sore throat, nasal congestion, rhinorrhea, and cough, as well as a number of other systemic symptoms, including enteric symptoms, joint pains, and muscle pains. And children will also present with, little babies will also present with a sepsis-like syndrome. They also have acute otitis media, a pertussis-like syndrome, bronchiolitis, and pneumonia. There are also febrile seizures, encephalitis, encephalopathy, Ray's syndrome, status epilepticus, and sometimes, unfortunately, these children may die. There's also, when death occurs, it can be from myocarditis, and they can also have bacterial co-infections with Streptococcus pneumoniae, which is circulating, as I said before, group A Streptococcus, and also Staph aureus. It is treated with Tamiflu, which is available locally, and it is prevented to some extent with the annual influenza vaccines, which are available locally, but not available to all. And Tamiflu, if there is household exposure, and we can prevent its transmission through infection control. Measles, I think, as I said before, is caused by the 7 C's, as related to cough, coryza, conjunctivitis, cephalocaudal centripetal rash, and Koplik spots, K for C, Koplik spots. And the respiratory presentations include otitis media, bronchopneumonia, laryngotracheal bronchitis, and croup. And they also can have a secondary bacterial pneumonia apart from the viral measles pneumonia that they have. This is also associated long-term with subacute sclerosing panencephalitis with behavioral and intellectual deterioration. after a natural measles infection. Deaths will occur in children who are young, those who are immunosuppressed, and those who are malnourished. Mycoplasma pneumoniae is also very important. This is the bacterium that was surging and is surging in China. And this is a frequent cause of upper respiratory tract infections, lower respiratory tract infections, bronchitis, and pneumonia, primarily in the older child. These children represent with cough and as well as malaise, fever, and headache. And these school-age children, while the majority of them will be mild, with cough, which is productive, and it can go on for up to 4 weeks. They just cough, 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 walking pneumonia, and they'll have crepitations and wheeze. There's also sickle cell, which we have here in Jamaica. Those patients can have pleural effusions and acute chest syndrome. There are also some more severe manifestations, which can include aseptic meningitis, encephalitis, acute demyelinating encephalomyelitis, cerebral ataxia, transverse myelitis, hemolytic anemia, thrombocytopenia purpura, hemophagocytic syndromes, rashes, and so on. It is treated with primarily in our sort of setting by azithromycin. And here we have 4 different x-rays which show how it can present. This one is unusual. This one has a dense lobar consolidation, which is very unusual for Mycoplasma pneumoniae. However, here you have what we are more accustomed to, which is the patchy consolidation, which is present in both lung fields. And here we have a nodular opacity in the third one, and in the third one there is bilateral parahilar or parahilar or perihilar infiltration. What is concerning, however, is that pediatricians right across the nation have been complaining for quite some time that they are seeing a current surge in lobar pneumonias, primarily in hospitalized children who present with a long prodromal period, possibly related to influenza or SARS-CoV-2 or both, and they would have gone to several doctors, sometimes 2 or 3 doctors, and they would have gone through 2 or 3 courses of antibiotics. And a subset of these children with lobar pneumonias will have Streptococcus pneumoniae, septicemia, noted. Of great concern is that several of these children have pleural empyemas, which are organized, and a number of them go on to have necrotizing pneumonias and abscesses. One pediatrician came to me last week and said, but these children have increased inflammatory markers, so many of them, one behind the other, increased inflammatory markers. A subset of them are being admitted to the hospital, and they have a long, stormy hospital stay. This seems to be pneumococcal pneumonia. We are undergoing a local surge here in Jamaica. So we know that Streptococcus pneumoniae causes a high morbidity and a high mortality in children. We know that children normally carry this pathogen in the back of their throat, nasopharyngeal carriage, up to 90% in a resource-limited setting. So can you imagine if the children were locked away and the immune system was not being stimulated by nasopharyngeal carriage during the non-pharmaceutical intervention period of the pandemic? Once we opened up, it means then that these children were now at risk for, they were now seeing Streptococcus pneumoniae for the first time. These respiratory infections that our children would be seeing, getting are acute otitis media, sinusitis, mastoiditis, pneumonia, and pleural empyema, which we are seeing in our hospitals. It also disseminates, causing septicemia, meningitis, endocarditis, pericarditis, peritonitis, and arthritis. Risk factors will include previous infections, again, the same influenza which they didn't see for 2 to 3 influenza cycles or seasons. Here in Jamaica, we have our sicklers and our patients with HIV/AIDS who would be most at risk. We also have patients who have immunodeficiencies and those with chronic heart, lung, and renal diseases. The symptoms, as we all know, would include high fever, chills, ricors, and malaise, a cough, which would be purulent, with green, yellow, or bloody sputum in the older child. They'll have rapid bleeding, breathing, or difficulty breathing. They'll have chest pain, which is pleuritic. And in the young children, they can present with ear pain or ear tugging or ear boxing and purulent draining. The physical findings will include pulmonary consolidation. And the blood culture, as I said before, can be positive in a subset, about 25% of cases. They present with high white cell counts with a neutrophil predominance. Radiologically, they present primarily with a lobar pneumonia, but we know they can also present with a bronchopneumonia. And we know that a round pneumonia, as shown here, is also consistent with Streptococcus pneumonia. These children can be treated with beta-lactam antibiotics, including penicillins or the cephalosporins, as we heard just now preceding. Augmentin is excellent. Cefuroxime is excellent if you're treating on the outpatient. For those who are admitted to hospital, if they come to us and they have real serious pneumonias, as we spoke, we could start with ceftriaxone or even Augmentin, IV Augmentin. I don't know if cefuroxime is available in all of our hospitals. And we also can admit and use vancomycin until the patient settles, to be sure, just in case there is a penicillin-resistant strain that is implicated, especially in sicklers. Prompt response to antibiotic therapy usually occurs in those who are in uncomplicated pneumonias. The pleural empyemas and lung abscesses is what is very, very concerning. So these patients can have a transudate or an exudative effusion, which occurs right next to the focus of lung consolidation. So these patients can present, the subset, those who are sick, very, very ill, go on to have worse disease, can have prolonged fever, chest pain, prolonged shortness of breath, respiratory distress, worsening of symptoms, despite the fact that you are using antibiotics. And really, sometimes it's because you have pus somewhere. Remember, if you have pus somewhere, as long as you have pus somewhere, you're gonna have that high swinging pyrexia. And that is what the exudate is. The pleural empyema is an exudate. Examining these children, they can be toxic. They'll have stony dullness to percussion when you examine the chest where the fluid is. They'll have a pleural rub and they'll have splinting of the chest, and they'll breathe very shallowly because of the pain that they have in breathing deeply. And because of the fact that the transudate or exudate is just so big. The pleural tap can be transudative or exudative. When it is exudative or it's an empyema, the color is thick and purulent. The gram stain can show evidence of GPCs in chains or clusters as it relates to group A strep, Streptococcus pneumoniae, or even Staphylococcus aureus. But for today, we're talking about group A strep and, of course, Streptococcus pneumoniae. The protein is high, the glucose is low, the pH is low, the lactate dehydrogenase is high, the white cell count in the pleural tap is also very high, and it's a predominance of neutrophils. Here we have a child with a really bad pleural fluid collection, and you have complete opacification of the left hemithorax with tracheal and mediastinal shift to the right. And on the left, there is a large pleural effusion, as you can see it on the chest x-ray here too. And you have a large pleural effusion you can see here, which has caused near complete collapse of the left lung with atelectasis. So the treatment has to be chest tube drainage, which should be done early. If you do not do it early, then what happens is that the fluid becomes loculated, and you have these thick fibrinopurulent strands which bind the parietal pleura to the visceral pleura, and you get trapped lung syndrome. So although you have the the chest tube there, nothing is coming out. These patients go on to have trapped lung syndrome and necrotizing pneumonias and abscesses. And essentially, sometimes the surgeons have to actually go in and do pleural decortication or pleural peels if this is organized. We treat with parenteral antibiotics for a long time. And again, because we're worried about drug-resistant Streptococcus pneumoniae, the preference is ceftriaxone along with vancomycin for a long time. You can pull back if you have sensitivity patterns or as the child improves. Other complications include abscesses, unfortunately, and bronchopleural fistulae. And you can imagine if this child's pleural empyema is not drained, then without surgical drainage and prolonged antibiotic therapy, this child would likely die. Now let's talk a little bit about group A strep infections. This causes pharyngitis, tonsillopharyngitis, sore throat, tender cervical adenopathy, petechiae, and the strawberry tongue, as you see here. It also can go on, as our ENT colleagues will tell us, to cause peritonsillar and retropharyngeal abscesses, and also suppurative cervical adenitis. They also have bacterial sinusitis, otitis media, and mastoiditis. This is a serious infection. Scarlet fever can go on, will develop from pharyngitis and cause skin pyoderma with an erythematous sandpaper rash from the group A strep exotoxins. And there's a wide variety of multisystem presentations, which include erysipelas, cellulitis, bacteremia, pneumonia, sepsis, endocarditis, pericarditis, septic arthritis, necrotizing fasciitis, which is seen here, which is so terrible. This is after the surgeons have already debrided it. Osteomyelitis, myositis, surgical wound infections. Lucky for us, penicillin is a very good antibiotic, and therefore strep throat should be identified and treated early, and it will reduce the suppurative infections and long-term complications. And just to go through 60 cases of group A strep bacteremia septicemia, here seen at 2 children's hospitals in the United States. You'll see here that some were immunocompromised, some had varicella, and 2 had cavernous hemangiomas. But most of the children, up to almost 90% of them, had an identifiable focus of infection, either in the respiratory tract for 19 children or the skin. Metastatic foci of infection included osteomyelitis, septic arthritis, and meningitis. 7 episodes were nosocomial. In other words, this infection is not necessarily only a community-acquired infection. And 4 of the patients died. 2 were severely immunosuppressed. 1 had extensive hemorrhagic varicella. 1 had hemorrhage into a large cavernous hemangioma of the skin. And the 4th has sudden infant death syndrome. So bacteremia with group A strep continues to cause infections in children, even during the antibiotic era, when lovely penicillin was available. Now, influenza and varicella vaccines may mitigate outcomes. And I have to speak to streptococcal toxic shock syndrome, because this is really, really, really terrible. We had a colleague whose 5-year-old son essentially presented with this a few weeks ago, again during this period. And essentially, you can have a child who has toxic shock syndrome, who has isolation of group A strep from a normally sterile body site, whether it be the blood, CSF, peritoneal fluid, joint, pleural, or pericardial fluid, or a non-sterile site, including the throat. And these children will present with hypotension with 2 or more organ systems involved, including renal, coagulopathy, hepatic, skin with soft tissue necrosis, necrotizing myositis, or gangrene. We treat these children with fluids to maintain the cardiac filling pressure and to prevent end organ damage. We give anticipatory treatment for multi-organ failure. We try to kill the organism with a bacterial cell wall inhibitor like penicillin or cephalosporin that we just heard about, and we also use decreased enzyme, toxin, and cytokine production with a protein synthesis inhibitor, such as clindamycin. So this is one of the few situations in pediatrics where you find yourself using penicillin and clindamycin to treat an infectious disease, and both are given at the same time. We also give intravenous gamma-globulin, and if there is necrotizing fasciitis, we manage it with the surgeons with incisional biopsy and resection of the necrotic tissue. We also need to remember there is post-streptococcal acute glomerulonephritis and acute rheumatic fever. We were seeing quite a few of these about a year or two here in Jamaica. Just to remind us that the major criteria we look for are carditis, pancarditis, arthritis, major joints, chorea, subcutaneous nodules, and erythema marginatum, along with the minor criteria and evidence of a preceding group A strep infection, which usually is a pharyngitis. And this now is bacterial rhinosinusitis. And we identify this in 3 ways. This is a patient who will have persistent symptoms and signs, completing with rhinosinusitis lasting for 10 or more days, who is not clinically improving. And this is of strong, low, moderate evidence. We also have patients who have severe presentation with high fever and purulent nasal discharge or facial pain, and this will be going on for 3 to 4 days at the beginning of the illness. And finally, you have a patient presenting with worsening fever, headache, or an increased nasal discharge after an atypical viral respiratory tract infection, which lasted about 5 to 6 days with an initial improvement, and now it's just deteriorating. And all of these 3 have strong, low, moderate evidence as related to the guidelines for bacterial rhinosinusitis in children from the IDSA. Now, the pathogen that we are most concerned about is Streptococcus pneumoniae, although there are others that may be implemented or implicated, you know, H. flu, Moraxella catarrhalis, and so on. So we tend to use augmentin, and we heard earlier on that this works really well for Streptococcus pneumoniae. And again, this is strong, moderate evidence by the IDSA guidelines. There's also high-dose augmentin. If you suggest in the community that drug-resistant Streptococcus pneumoniae or severe disease is endemic, and meaning over 10%. For us, I guess that we would use it in maybe our sicklers or in our patients who have an immunodeficiency, or a patient who has sickle cell disease or HIV, since we don't know what our community rates are in particular areas of the country. If the patient is in daycare or there's recent hospitalization, again, this is strong or moderate evidence. We do not use the macrolide, Bactrim, or doxy as the primary reason for strep pneumo, although you may add it. You could add a macrolide if you're worried about a pathogen that is macrolide specific. The duration of therapy is 10 to 14 days. And this is weak, low, moderate evidence. Saline irrigations and intranasal steroids are recommended. Topical, oral steroids and antihistamines are not recommended. And this is strong, moderate evidence by IDSA guidelines. And if the patient is seriously ill, has failed antibiotic therapy, or is immunosuppressed, then we should probably do specialist referral with CT scans and ENT referral. So that is ENT or pediatric referral for hospitalization. This is acute otitis media, and then this is moderate or severe. It is defined by moderate or severe, a bulging of the tympanic membrane or new onset otorrhea, which is not due to otitis externa. There also should be mild bulging of the tympanic membrane and recent onset in the last 2 days of otalgia, and this may be evidenced in a young child by holding the ear or tugging at the ear or rubbing at the ear in a nonverbal child, or intense erythema of the tympanic membrane. There should also be a middle ear effusion using pneumatic otoscopy and or tympanometry, which I know we don't do, but we really should be doing that in our children when we examine the middle ear. Streptococcus pneumoniae in our setting is the most important cause. And essentially from the guidelines that are set together by the AAP and the CDC, mild cases with unilateral symptoms in children 6 to 23 months of age, or unilateral bilateral symptoms in children 2 years of age are watchful waiting. But in our setting, I don't think we can do that. Remember now in the United States, we have vaccines for Streptococcus pneumoniae and Haemophilus influenza type B. Here in Jamaica, we only have vaccines for going to everybody for Haemophilus influenza type B. So despite the fact that we know that viral pathogens are primarily the ones that are implicated, we might want to start first-line antibiotics in patients who have mild otitis media. And again, the medication is amoxil, it's first-line therapy. If the person has not received amoxil in the last month, amoxil clavulinate, if amoxil has not been taken in the last 30 days, should be given if the child has purulent conjunctivitis as well as a history of recurrent acute otitis media, which is unresponsive to amoxil. For those who have penicillin sensitivity, the drug that you may choose is cefuroxime or ceftriaxone. And prophylactic antibiotics are not recommended to prevent acute otitis media. Looking at laryngotracheal bronchitis or croup, I mentioned this to some extent earlier on when I was speaking about RSV, but I thought I should use it here as well to compare to bacterial tracheitis and also to epiglottitis, since these are the middle infections of the middle respiratory tract. So it's not only caused by RSV, but also by parainfluenza viruses and human metapneumoviruses. And the patient will most likely be a 2 to 3 year old child with nasal congestion and runny nose, inspiratory stridor, a barking cough, hoarseness, and fever. On examination, you will see a decrease. You need to assess for the degree of inspiratory stridor and air exchange and respiratory distress, because we are trying to figure out, does this child need hospitalization? Or more important, does this child need an artificial airway, which is like 1% of the population? The X-ray will show this steeple sign as shown here, which is narrowing of the trachea below the margins of the piriform fossa as shown here. And we treat these children, as we said before, with humidified air, oxygen, nebulized drugs, epinephrine, corticosteroids, and another number of other modalities. And the prognosis is usually excellent. Here we have epiglottitis, which most usually would be caused by Haemophilus influenza B. I remember during my residency, I'd see at least 3 of these cases per year. But since we have implemented the H-flu vaccine, these cases are not so popular. But given that Streptococcus pneumonia and group A Streptococcus are surging, and given the fact that these two etiological agents are related to acute bacterial epiglottitis, I thought I should speak about it to this group. So the patients will present with inspiratory stridor, high fever, sore throat, a muffled voice, drooling and pooling of the saliva, and they will sit forwards on the panting dog side. The child refuses to swallow, and these classic signs will present within 3 to 6 hours. And we should also seek the immunization history to ensure that the child has Haemophilus influenza type B vaccine. How do we make the diagnosis? Clinically, this is one diagnosis that we make standing away from the child. We look, but we do not touch. We carefully observe for the complaints that I just spoke to. And essentially what we do, we call for the anesthetist and we call for the ENT surgeon. Hopefully one is nearby. And the diagnosis is made in the operating room, or if it is an emergency, it can be done in the emergency room, and this is done by direct laryngoscopy and tracheal intubation. These patients will, by this time now, be having inspiratory stridor, intercostal and subcostal recessions, fever, and when the direct laryngoscopy is done, the epiglottis, the swollen epiglottis will be shown. This is one situation where we do not use a tongue depressor to examine the patient because the gag reflex will cause the epiglottis to flop backwards and block the trachea. And it means then that you probably may not have a trachea to intubate, and you need to go for tracheotomy. And remember that the trachea of the child tends to be depressible because remember the tracheal rings are not calcified. So again, you'll need an expert to help you. Treatment, you need to secure the airway. And once the airway is secured, then you can do your blood cultures and you can start broad spectrum antibiotics, ceftriaxone and vancomycin. The child should be managed in the ICU. And the prognosis is good if airway management is optimal. And what I have here is the two signs, radiological signs, the epiglottitis with the thumb sign for the epiglottis and the steeple sign for croup as it relates to, but both of them will cause stridor because essentially you cannot get air into the trachea. And then this is the big one, the big one, bacterial tracheitis. And again, this is unusual, but because Streptococcus pneumonia and group A streptococcus are surging, I would be remiss if I did not discuss this. And essentially, these children will present with acute respiratory distress, with coughing, and some of them will actually cough up the pseudomembrane of the trachea that is lining the trachea. They'll have stridor commonly. Rarely they will present with fever, nasal congestion, sore throat, hoarseness, wheezing, but sometimes they'll present in shock and they'll present with cardiopulmonary arrest. So the examination findings, while you're examining them, can vary from mild stridor to respiratory arrest. Have to be careful. So moderate stridor, respiratory distress, and fever would be what would be obvious, but still they can have toxicity, shock, agitation, lethargy, cool extremities, poor capillary refill, and tachycardia. And direct laryngoscopy is diagnostic because you will see the pseudomembrane as you see there, and it is also therapeutic because sometimes you can remove the pseudomembrane during that time. What happens though is that as you're moving in the laryngoscope, sometimes what can happen is that you're actually peeling, for want of a better word, the pseudomembrane and pushing it down. And sometimes this can actually block the airway lower down. So even this is dangerous as well. If an X-ray is done, you can see what you call the tram-track sign, as noted here, and you can see the airway is barely showing here, right? So again, the whole idea to treat these patients is to remove the pseudomembrane, do your blood and tracheal cultures, and give broad spectrum antibiotics and manage these children in the ICU. And sometimes they will have subglottic stenosis as a complication for those who get better. but sometimes they will actually improve. And this is my last slide. You're going to ask me now, so how do we prevent all of these terrible respiratory pathogens that are now circulating, not only around the world, and I dare say here too? First, we can do infection control for them, whether it's by contact or droplet or standard precautions in our hospitalized patients. We need each to practice individually respiratory hygiene and cough etiquette. We need to keep our distance from ill people, stay home when ill, get tested and seek medical care as needed. Wear our masks as appropriate, whether to protect ourselves or if we ourselves are sick, we should wear our mask if we have to go out. Ensure good ventilation and practice regular hand washing. Related to vaccines, we do know that we have vaccines that prevent respiratory illnesses. Here in Jamaica, we have the diphtheria vaccine, we have the whole cell pertussis vaccine, we have the measles vaccine, and we have the Haemophilus influenza type B vaccine, which gets to everyone in Jamaica's national schedule. But I would make a ploy for implementing annual influenza vaccines in children, and certainly the pneumococcal vaccine, the conjugate vaccine, and the polysaccharide vaccine for all our children. At the moment, I know the children, it is offered to the children in private practice, which is about 10% of our population. And the Ministry of Health has a stock of vaccines that is used for children who are immune suppressed. And that population includes patients with sickle cell, HIV, those who are on dialysis, and a number of other ones. But I would say with what is happening now that we probably should ask the Pediatric Association of Jamaica to reach out and ask them to make these vaccines available. Treatment should really be done early as it relates to the use of antivirals and antibacterials as shown for pathogen-specific organisms, and where surgical intervention is needed, then that should also be included. And with that, I guess I should stop. I thank you very, very much for your attention. Thank you so much.
Professor Christie, what a feast you've given us. What a feast. You have 662 people eating from the table.
Wow.
Yes. And they are, you should hear the thanks that they have been giving you. Very informative, excellent presentation. Wow, very interesting.
Thank you.
You know, it is really an excellent presentation. Oh, very eye-opening. That's very scary. Trapped lung syndrome. And a lot of claps, you know. Wow, this is amazing.
Thank you.
I'll invite people to put their questions into the Q&A, please. While they're doing that, I'm going to invite Aristopharma Williams to do their presentation. So put your question and answers for Professor into the question area, please. And
Thank you.
You're welcome. Aristopharma, over to you.
Good day, everyone. Today, the team at Aristopharma would like to highlight a few of our products that represent our commitment to quality and innovation. We are endeavoring to ensure that your patients benefit from products that meet their needs. Because at Aristopharma, quality is the unit we count. With modern technologies, we are able to quickly connect and access critical information in the blink of an eye. These capabilities are made possible through the use of apps. And we all know that by utilizing these apps we can be rewarded with convenience. They may also allow us to create and maintain long-lasting connections. And sometimes, They just provide valuable relief through entertainment. But today, we want to bring your focus and attention to a few different types of apps. Simply put, we want you to pay attention to our Aristopharma products. Now let's enter our App Store. Our first app that we will be focusing on today is our Flutica. Flutica is our fluticasone furet at 27.5 micrograms per spray. Some of the benefits of Flutica include a gentle mist, no drainage, no aftertaste, and low bioavailability. Next on our list is our Aeroflows. A few features of our Aeroflows include the affordable prices, the long history of treating asthma symptoms, its ability to reduce the exacerbation of COPD, and its bronchodilator and anti-inflammatory properties. Now, in keeping with our apps for asthma, we would also like to highlight our Soulflow. Soulflow is our salbutamol at 100 micrograms per puff, offering 200 puffs in a wonderful CFC-free formulation. Soulflow has a rapid onset of action and acts within 5 minutes. The relief from Soulflow lasts up to 4 to 6 hours and costs less than $300 after the NHF subsidy is applied. And for your patients who may suffer from dry eyes, we also have an app for that. Introducing Cystair. Cystair is our unique combination of polyethylene glycol and propylene glycol. Now with Cystair, both polymers combine to create a unique formulation that offers 6 times the lubricity of most other drops on the market. So we are encouraging you and your patients to feel the hydration. So now, it's time for a practical demonstration of our apps. Let's say you are visited by a patient who has been plagued with seasonal allergies. Now they are showing signs of shortness of breath, indicating a likely asthma attack. This patient can certainly benefit from a few of our apps. To start, you can place the patient on Flutica at 2 sprays in each nostril once daily for up to 14 days. Secondly, you can add our rescue inhaler Soulflow at 2 puffs every 4 hours. Finally, for maintenance, you can add our Aeroflow at 2 puffs twice daily to ensure that the patient gets lasting relief. Now all you need to do is to just add your signature and send your patient on their way to access their new apps at the nearest pharmacy. Now as we close, we would like you to keep our Flutica, Aeroflow, and Cystair in mind, and we hope you enjoy the rest of the conference. Thank you.
Thank you very much, Aristopharma. And such as Aristopharma Williams, so I think they're combined. Yes, let's look at the Q&A. Professor, look into the Q&A and let me see where we're going to be here now. Yes, this person is asking, is there any form of tablets for immunosuppressed kids? For example, Paxlovid is given to immunosuppressed adults.
Paxlovid is used for outpatient treatment and in patients who present in the United States and in other parts of the world for COVID-19. I have asked for it here, but it is not available on the island. And given the fact that our pediatricians are reluctant to use even remdesivir, which is an antiviral drug, I do the infectious disease consults for COVID-19 at UA, and I have been doing them consistently from the beginning of the pandemic. And in situations where I have suggested it, and it was available, they didn't use it. So I don't know that they'd like Paxlovid. Paxlovid also has a number of complications, including severe diarrhea. And some people would argue that if you wouldn't necessarily want to exchange COVID for severe diarrhea in a child. So I doubt that if it was available, we would use it, but it's not available on Ireland. And I asked about this up to about a week ago.
All right,
And
thank you.
I called the pharmacist to find it, and it's not available on the island.
Okay. Daniel Lester is asking, would the immunity gap explain the rise in measles in places like the UK as well?
Yes, oh yes. Remember, as I said before, with the immunity gap, immunizations, not just non-pharmaceutical interventions, but immunizations for measles were not given. So therefore, you can imagine that when you open up for those, once measles starts to circulate, and remember, one case of measles is an epidemic. It means then that, and the measles is one of the most infectious viruses that we know of. Essentially, it will cause clusters of measles cases. So, yes, so it's happening in the UK, it's happening all over the world, it's happening in the United States. And I think there's an outbreak going on right now. There were some cases that were identified in an airport. Yeah, so.
Can measles wipe out immunologic memory?
I don't know about that. And maybe I shouldn't comment because I don't know.
I saw a study years ago that it said what it meant in my head was that if somebody got measles and they had vaccinations before for other conditions, that it would wipe all of that out as well. I'm going to have to, I haven't seen any more.
I don't know about that for sure, but what I do know for sure is that we always teach that natural measles gives lifelong immunity. Once you have a measles infection, you have lifelong immunity.
All right, thank you. For the RSV, do we have local access to the Abrexy offered in the United States?
No, we certainly do not. We do not have, it's not available to us, neither Abrexy nor Abriso. Abriso was just approved, I think, late last year, and it's given to adults because today I spoke about RSV in children, but what is happening in the United States now is that they're not only seeing RSV in children, but they're seeing it in adults as well too, and in the elderly. And therefore, it's given to adults, it's given to the elderly, and it's also given to pregnant women in the third trimester to supposedly prevent get transplacental antibody to the baby so that the baby does not get RSV. And again, those are drugs that are available in the United States, but not here. Similarly, the humanized monoclonal antibody, which is given monthly in high-risk children, is not available here either.
Okay. Dr. Sloper, she's asking, in countries such as Jamaica, in countries like Jamaica, we have much better ventilation than in colder countries, and SARS-CoV is now accepted as being airborne. Is there any data on higher transmission rates in the tropics in those living or working in ACs?
That's a very specific question, and I prefer to defer answering that.
All right, then. For how long do you give antibiotics for strep pneumonia?
It depends on what the infection is. It depends on where it is. It depends on how complicated it is, right? So if it is an outpatient, if it is, for example, acute otitis media or rhinosinusitis, maybe 10 to 14 days. If it is a child with uncomplicated pneumonia, maybe 7 days, 7 to 10 days. If a child has a complicated pneumonia with lung abscess or with pleural empyema, and you're doing all these different things, you may go up even up to, I recommend even up to 4 weeks.
Okay.
And
This
it
person,
depends, because some of it we can use for the acute management, and then, you know, we can tailor and change the antibiotic course as the child gets better.
to
You know,
keep
so you can pull away.
reassessing.
You can reassess and pull away. But I would say it depends. And I think
Yes.
I'd be correct if I said that.
Yeah. What drugs are nebulized to treat pneumonia?
Nebulized drugs to treat pneumonia. Okay, so essentially what we will be doing now is giving we'll be treating viral pneumonias. So for RSV, for example, we can give racemic epinephrine in for RSV related croup. And this has been shown to reduce length of stay, intubation rates, and ICU admissions. And you can repeat doses for 2 to 3 hours for up to 3 consecutive treatments. And these patients, it would probably reduce the recurrent stridor. You can, and this, it can also be given, epi can also be given in a nebulizer in patients who have moderate to severe croup. And it is found to work even faster than dexamethasone. We can give aerosolized ribavirin, yeah. So that, you know, so those are some of the things that we can use.
You had answered the question. The next, this other person asked about the role of epinephrine in croup, but you answered that. This other one here. Thank you for an excellent presentation. You mentioned a phenomenon where due to recurrent infection on a chest X-ray, you may not see any infiltrates. Can you please explain this again?
I am not sure I understand that question.
Let's move on. Is there enough information given at antenatal clinics? For some reason, most mothers' coping skills are below par, especially when their child or adult has respiratory issues. So this is about health education and the communication.
As health education in the antenatal clinic, that's really talking about our obstetricians and the treatment and care that they would give. I'm not sure what exact advice they give, but certainly our pediatricians and our public health nurses throughout our clinics, public health clinics, and also in private doctors would be giving the appropriate treatment, giving the appropriate advice as it relates to this.
And our friend Anna Brown Morgan, she's asking,
Hi,
how do you suggest we try to overcome vaccine hesitancy? What works?
Well, we can continue to teach, and I wish I could tell you what our vaccine uptake rates are post-pandemic, but unfortunately I wasn't able to get that information from the ministry. But here in Jamaica, we have been very, very, very successful with not only with regards to teaching our parents about vaccines and adhering to vaccine messages and ensuring that the children get the vaccines they need for them to go to school. But so I think we're doing pretty well, you know, as compared to other countries. So I really, when it comes to our children, I know our mothers are fiercely protected, and I know the children have to go to the public health clinics or have to go to their pediatricians for you know, well maintenance care, and I know the vaccines will be offered there, and there'll be the one-on-one counseling that would be given. When it comes to adult vaccinations now, like COVID, I'm not so sure I can speak to that because, as you know, as I showed you, it was just 24% uptake for 1.5 million doses that were given here in Jamaica, as compared to other countries that had, you know, went up to 96% like in Cayman. And I think we were second to last with Haiti at 3% and we at 25%.
Professor Christie, thank you so much. Your presentation was and will continue to be phenomenal. That is why we stay put in our seats, because you had us all riveted. We didn't want to go anywhere. We wanted to hear every single word you say. Thank you so much. You are an excellent teacher, not a lecturer.
Oh my.
Excellent teacher.
Thank you.
You know, and I could
Very
hear the
kind.
and the passion, the total passion, you know, to train us, because all of this is to save lives and to make us current, you know. Thank you so much for helping all of us to take the higher step.
Okay. Thank you so
Thank
very
you
much,
again.
Dr. Buckland. You're very kind, and thanks to the audience for listening and for your responses, your very positive responses. It was my pleasure and my privilege in preparing it and also in presenting it. Thank you so very much.
Thank you, Professor. All right, at this time, I'm going to invite Abbott to present to us the products that they have. And then after that, I will tell you who comes after that. But Abbott, here you come.
Thank you very much. Let me get to my slide. Are you seeing the Abbott A on the screen?
Yes, I see.
Okay, great. Good afternoon. As mentioned, my name is Paul Russell from Abbott Nutrition. And I'd just like to thank the CCFP for the opportunity to highlight a few of Abbott's products.
Association of General Practitioners.
Oh, sorry.
That's okay.
So sorry.
It's okay. They are
AGPJ, right. Thank you for the correction. Abbott products spans all stages of life, from infants through toddlers, young adults, and to the aging population and those with special health needs. So let's now look on Pediatrician, which provides nutrition for growth and immune support. Now, Pediatrician provides antioxidants for immune system support. It has DHA omega-3 for brain and eye health. It has protein to help build muscle and vitamins and minerals. Now, Pediatrician with dietary intervention is seen to improve weight by 8 percentile for catch-up growth versus dietary counseling alone. Ideally, we want to utilize the right Pediatrician product to find the right solution. And there are 3 types of Pediatricians available in the retail market. We have Pediatrician Original, we have Pediatrician with fiber, which is now in a new bottle, and we have Pediatrician Sidekicks. And Pediatrician can be used as a snack, in a recipe, or with meals, as mentioned earlier. So let's now look at Pedialyte, which provides hydration for all. And by all, I mean adults and children. Whether it be for excessive sweating, vomiting, or diarrhea, and rehydration because of extreme heat. Pedialyte, given early, helps to manage dehydration and is scientifically designed for fast rehydration to help patients feel better fast. Just a reminder that several factors can lead to mild to moderate dehydration. That could be fever, diarrhea, vomiting, increased fluid needs during breastfeeding, or occasional morning sickness during a normal pregnancy. And the signs of dehydration include headache, thirst, fatigue, and constipation. So whether it is you choose Pedialyte Advanced Care, Pedialyte Classic, or Pedialyte Freezer Pops, please recommend Pedialyte for advanced hydration to help patients feel better fast. Now, as usual, I include my business card with my cell number, which is 489-6093, and my email address, which is paul.russell with 1 L @abbott.com. And all Abbott products are distributed by CareMed. So please feel free to contact me should you have any questions, queries, or concerns. Thanks again, and please enjoy the rest of the conference.
Mr. Russell, thank you so much for your presentation. At this time, I invite Health 2000 Canada to come and share with us what they have.
Good afternoon. Happy New Year and a wonderful 2024 to you all. Good day, this is Amoy Rickman from Health 2000 Canada, or H2K, highlighting some products tested, proven, and effective in the pediatric population that is priced for affordability. Breathing is easier with H2K Broncho Air Salbutamol 100 microgram inhaler. When your child is coughing, wheezing, and feeling breathless, use H2K Broncho Air for rapid relief. Broncho Air rapidly opens the airways and relieves chest tightness, usually within 5 minutes, so your child can breathe more easily. H2K Broncho Air, an affordable, effective solution for the management of asthma and COPD. Keep Broncho Air close for the onset of an asthma attack. Breathe easier with Asabec beclomethasone 50 microgram inhaler and control symptoms such as wheezing and shortness of breath caused by asthma and COPD. Use Asabec to reduce swelling and irritation in the airways. Asabec does not replace your rescue inhaler such as Broncho Air in the onset of an asthma attack. When using Asabec, improvement may occur as soon as 24 hours. However, you should still continue to use Asabec even after your child feels better. Control your breathing. Control your life with H2K Asabec beclomethasone inhaler. H2K SCSI azithromycin 15 ml suspension with 200 mg per 5 ml provides efficacy and convenience with its once daily dosing for children and the elderly. SCSI effectively treats upper respiratory tract infections, acute bacterial sinusitis and acute bacterial otitis media, pharyngitis, tonsillitis, skin and soft tissue infections. SCSI is not recommended for infants below 6 months of age. However, it is the only azithromycin suspension that provides a delicious mint flavor enhancing compliance. When you have wet, dry, or any cough, use Dawacough, an excellent mucolytic, expectorant, and bronchodilator in one. Dawacough contains just 2 mg salbutamol, 4 mg bromhexine, 100 mg guaifenesin, and 1 mg menthol in one great tasting syrup. Dawacough is excellent and effective in the treatment of reversible bronchospasm in bronchial asthma, bronchitis, pulmonary emphysema, or just in the symptomatic relief of coughs and catarrh in flus, cold, and mild throat infections, and any chesty coughs. The dosage for Dawacough is 2.5 ml 1 to 3 times daily for children 2 to 6 years, 5 ml 1 to 3 times daily for children 6 to 12 years, and 5 to 10 ml 1 to 3 times daily for children 12 years up and adults. H2K acyclovir 5% cream can be used in the treatment of severe chickenpox infections in children. Best results are achieved if treatment begins within 48 hours of the onset of the rash. Acyclovir is effective in reducing the maximum number of lesions in otherwise healthy children with chickenpox. Apply H2K acyclovir cream to affected areas every 3 to 4 hours, 5 times per day for children 6 years and older. For children under 6 years, use and dose must be determined. Please write H2K before the drug name on your prescription. Follow us on Instagram at Health2000 Canada. Thank you.
Thank you very much, Ms. Rickman, for your presentation on behalf of Health 2000 Canada. At this time, you're welcome. At this time, we have someone very interesting. He plays with sticks and stones. How does that nursery rhyme go? Sticks and stones may break my bones. And his words will help us in the management of common fractures in the pediatric age group. Now, who is this person I'm talking about? It is none other than Mr. Shamari Prince. Who is he? He's a pediatric orthopedic surgeon at the Bustamante Hospital for Children. He has his B.Med.Sci and MBBS and DM in orthopedics from the UWI Mona. Got a fellowship from the Royal College of surgeons in England in soft tissue knee reconstruction and in pediatric orthopedics between 2018 to 2021. He's a member of the British Orthopaedic Association and a member of Sherrard Society. Special interest in cerebral palsy, pediatric hip preservation, soft tissue knee reconstruction, and deformity correction. His interests are outdoor activities, swimming, snorkeling, football, hiking, and long romantic walks on the beach. So please help me welcome. Sticks and stones may break our bones, and his words will help us in the management of common fractures in the pediatric age group. Dr. Prince, your turn.
Hi, good day. Give me a few seconds, just trying to organize this thing. Hello, can you see my slide?
Yes, we can see the slide.
Okay, great. Second.
Go on slide share though.
Yes.
Slide share. There you go.
Thank you. Sorry for the delay. Thanks for that introduction. I'd like to thank the Association of General Practitioners of Jamaica for inviting me to discuss some common pediatric fractures. Hopefully at the end of it, we'll have a better knowledge of how to manage these patients. Because I know when it comes to fractures, non-orthopods are somewhat nervous, but don't worry, we're here to help. So let's start off by discussing what a fracture is. As we all know from medical school, is basically defined as a discontinuity of a bone. Fractures are very common in children because of numerous factors. Part of it has to do with skeletal structural difference, coordination, activity level, and some of these children are just fearless. Fractures can occur in any bone of the axial, or the peripheral bones, upper limbs and lower limbs, as well as, axial as in the central bones, and appendicular skeleton, which is upper limbs, lower limbs. But here we'll be discussing orthopedic fractures, so not skull, facial bones, mandible, ribs, etc. And we'll be discussing mostly the more common ones. All right, so we'll look at the overall epidemiology of pediatric fractures. It was noted that males are somewhat more susceptible, some ranging from 1.5 to as much as 2 to 1. This saying about the risk of getting it is about 20 per 1,000 for every year. And if you were to basically follow up the likelihood of a child getting a fracture up to the age of 17 years, it ranges about 20 to 34. Some studies actually said it's as high as 50% in boys, which I think is quite high. Incidence in the long bones, upper limbs are much more common to have fractures compared to lower limbs. Radius and ulna is about 60%, humerus 20%, leg bones 15%, and femurs 5%. There's some certain environmental factors thought to predispose children to fractures, and it's tend to be higher during these environmental factors, such as holidays, when you take breaks from school, playgrounds, parties, sports recreation, trampolines, which is a nightmare for an orthopedic surgeon, motor vehicle accidents, etc. And of course, we have to mention non-accidental injuries or child abuse, which is something we're very much against. Now, what makes children prone to fractures, or what is so unique about the immature skeleton? So there's some disadvantages and advantages that we work with, and we just have to work with what we have. It's shown that bones heal much quicker in children compared to adults, and it's thought to be due to different factors. children's bones is covered by thicker periosteum. Not only is the periosteum thicker, stronger, it also is less adherent. This allows for greater remodeling potential, and this allows us to accept less than anatomical or perfect reduction. The physis is a specific weak part of the bone, and unfortunately, damage to this can cause growth arrest, and it depends on how much growth is left in that physis. So the younger the child, there's damage to part of the physis or the whole physis, then this will result in deformities and limb length discrepancies. Mentioned before, the physis is also has significant or markedly remodeling potential. The younger the child is, there is much more cartilage in their bones, or in their skeleton, I should say. And as such, it's easy to miss certain fractures on radiographs, especially around the elbow. Apophysis is another area that is relatively weak. And apophysis is just basically a projecting part of the bone, and I'll discuss this a little further. All right, so what we have noted is that in pediatric bones, they have significantly higher water content and lower mineral content per unit volume than adult. Therefore, it has a lower modulus of elasticity. What that means is basically it's less brittle. So it's more like a blade of grass or, you know, a green stick compared to ceramic, so to speak. And ultimate higher strain to failure. So therefore, it can take a lot more strain before it breaks compared to adults. It's relatively stronger in tension than in compression. As you can see in a cross-section drawing of adult and child bone, as in the center of the shaft of the bone. You can see it's more porous in the child, and based on those haversion canals, it tends to be more widely dispersed. Very good. No, so just to revise some anatomy to make life easier for everybody, so we're all on the same page. We're going to discuss the anatomy of the typical long bone. So on either end of the bone, we have the epiphysis, usually. That's bulbous and usually intraarticular cartilage-covered ends. As you can see in the picture of the femur on the right. The physis is what's just below the epiphysis, and this is what I mentioned before, is we have all this growing and is well organized and very, very important for longitudinal growth of the limbs. Also, you have the metaphysis, which is just below the epiphysis, and this is the part of the bone which tapers downwards from that bulbous part of the metaphysis, and that heads towards the diaphysis, which is just basically the shaft. This tends to be central and funnel shaped, and as mentioned before, interposed between the metaphysis. Now, the apophysis is a secondary ossification center. So opposed to the epiphysis, where there's usually a primary ossification center, apophysis has a secondary ossification center, which may assist with the width of the bone growing, that is. And important structures such as muscles and tendons, large muscles and tendons, insert into the apophysis and makes it more prone to fractures, especially avulsion fractures. Now, let's go into a little bit more detail of the anatomy. Not too much detail, don't worry. So the epiphysis, as mentioned before, ends of long bones and is usually intraarticular. It is completely cartilaginous at birth. And physicians need to have an idea of the appearance of ossification centers. Because as I mentioned before, it's primarily cartilaginous, and then usually in the center or off-center, it starts to ossify. And that the space that you have, or what appears as a space on X-ray, where the cartilage is of that ossification center, and what's left in the metaphysis, which has already ossified, it may look like a fracture. So that's why it's important to know what is a fracture and what is just basically cartilage around the epiphysis or at the physis. As it ossifies, this is very important, there is a significant change to the biomechanics. So certain parts of the skeleton, because of the level of ossification, it causes more or less like a stress rise or a stress area So there's certainly tend to have certain fractures around certain age groups, and this will all make sense further on, hopefully. Now the physis, as mentioned before, just under the epiphysis, so between the epiphysis and the metaphysis, it is highly organized and very dynamic. There are different zones to it, which you guys don't have to know unless you're in orthopedics. It consists of basically chondrocytes, which tends to undergo proliferation, differentiation, and then produces extracellular matrix, where you get your ossification further down, heading towards the metaphysis. And it's quite vascular, especially around that area of the metaphysis. And this is just a reminder of the Saltires classification, which I'm sure everybody knows. Just to run through it, it's basically a fracture which occurs through the physis and depends on which part it goes, whether into the metaphysis or epiphysis or both, or just basically a crush injury. And it fits into different patterns. And based on what type of fracture pattern it is, determines how we're going to address or fix these fractures. Metaphysis, so it is thinner, very important, and is more porous. It has a more porous cortex and increased trabecular bone. And it allows for an area of deformation without completely breaking, especially so in compression. That's where you get your buccal fractures, you can see in that picture on the right, or your torus fracture. So as the bone just tends to buckle, as opposed to have a complete fracture. So in a buccal fracture, it's not hasn't completely gone through, and these are inherently stable, as we'll go on to discuss. Now, this needs to be separated from a Park and Harris growth line, or some people call it the growth arrest lines. So this tends to occur after processes whichever transiently slow growth or increased mineralization. So if there's localized infection, localized growth plate trauma, or in regards to the pediatricians, if there's significant generalized illnesses, as I mentioned before, with your long COVID, etc. Bisphosphonates can also cause these Park and Harris growth lines. Now we come to the diaphysis. We're almost there. You guys are doing quite well. The diaphysis makes up the largest part of the bone. It's more or less, you can just say, as the middle. Has a much thicker cortex and less porosity compared to the metaphysis, and tends to have an increase in hardness. This is so markedly so in the femur. The periosteum, as mentioned before, is much thicker than that of the metaphysis. In fact, at the metaphysis is thinner, and then at the physis tends to insert at the level of the portion of the physis, and it becomes less adherent there. And because of the thicker periosteum compared to adults, has a significant greater osteogenic potential. And because the periosteum is so thick, we can use it more or less like a hinge, as seen in that picture there, to assist in our reduction. Important thing is not to be overzealous and break that periosteum hinge. Just makes everything somewhat more difficult. Now, in evaluation of these fractures, in situations where we have high velocity or multiple trauma, we need not to forget our ATLS guidelines, so your primary, secondary survey, and whatever adjuncts necessary. Issues with children is that, as we all know, they're poor historians, not their fault, and trauma may have been unwitnessed, so this makes life a little more difficult. So a full evaluation of the affected extremity needs to be done to localize where these issues or injuries are. Can't stress enough, distraction and rapport. You need to gain the confidence of the child, and you surprise so much information you can get out, sometimes more information than you actually wanted. You need to check the neurovascular status. This goes across the board, especially distal neurovascular status. And depending on where the injury and swelling is, this is very important to feel for the compartments, ensure it's not too tense, make sure they have relatively good range of motion distally and good sensation, because it's going to affect what we do from there on. We have to look at the skin for if there's any overlying skin changes, and more importantly, wounds, especially if those wounds are actively bleeding, especially with movement of the limb, which suggests that there's an open fracture. Just a little note I like to put that you can have intracompartmental blood loss, and this is more for high velocity trauma, and it can be somewhat significant in young children, example, fracture of femur. With that being said, however, that intracompartmental blood loss rarely ever, if any at all, would cause the child to have hypotension, so you need to look for another cause. Now, how do we evaluate for non-accidental injuries? This is something that we're very concerned about, and probably the most important slide, in my opinion. Now, non-accidental injuries are suspected if, one, there's a history, the mechanism of injury is not consistent with the fracture pattern or unwitnessed. Now, note, I mean, also these injuries are unwitnessed, so it doesn't mean that all of them needs to be referred or taken further. So what's important is to look for social cues. You know, if problems with the family dynamics, step parents, etc. So sometimes what your things you pick up with your history or discussing with the caregiver, whoever is there, sometimes that can give you more information or give you a better clue that there is something going wrong within the family. Now, we said across the board, if there's a femur fracture less than the age of 2, some say 18 months, sorry, high likelihood, or we need to investigate all of them for a non-accidental injury. If there's a humerus fracture less than 3, somewhat. If there are multiple fractures, this is very important at various stages of healing, especially the rib. They're saying that in some studies have shown that as high as 90% of cases are so associated with child abuse. But of course, you need to rule out or ensure that the child doesn't have brittle bone disease or osteogenesis imperfecta, which is not their fault in this case. Metaphyseal corner or bucket handle fractures. So let's look at these pictures to the right. So let's see if we can get, no, I don't have a pointer, unfortunately. So in that, the pictures that in the middle to the left, where the arrow is pointing at a metaphyseal corner fracture, usually involves that there might be some amount of twisting or bending or at that point. This used to be, we used to consider this to be pathognomonic, although you can get it in situations where there's no child abuse. When we see it, we're very much concerned. But more importantly, the pictures to the right of it, where we see the different bones. So it's so that there's fractures of the clavicle in the same child, fractures of the femur, distal radius at different stages of healing, tibia on both sides. Then that's significant. Top right picture, or picture at the top, is that of an X-ray of the right femur in a very small child. Suggested that there was no accidental injury. Very important to examine the child from head to toe, from top of the hair to the sole of their feet, to look for skin stigmata for bruises at different stages of healing, and more importantly, cigarette burns. I know that's extremely sad, but we do have to do that. And this is not only done at one point in terms of your examination. If you suspect it, there should be another follow-up in at least 72 hours to check. If anything is, if you have any suspicion at all, you need to admit to the hospital and contact social services as soon as possible. And then from there, we take it by doing skeletal surveys where we X-ray all the bones, as well as, depending on the age of the child, we will get an ENT as well as ophthalmology consult to look for any bleeding, hemotympanum, or any bleeding at the back of the eyes. And in some situations, we even order a cranial ultrasound or even a CT scan. Now, so let's just talk about, keep it simple again, radiographs. As usually where, if we suspect that there's a fracture, we start off with plain radiographs. I know these radiographs ideally should be orthogonal, that's a 90 degrees views to each other. So the anterior posterior view as well as a lateral of the suspected bone. If you're uncertain with where the tenderness is, because sometimes you just have very fussy children, it's not uncommon for us to X-ray the entire limb. Rather than that's in only situations where you're not certain. Please don't radiate the entire limb unnecessarily. Comparison views are not routine. However, they're only tend to be ordered after there's any uncertainty if you've gotten back your preliminary x-rays. And this is especially so around the elbow areas where, you know, you have a lot of cartilage still present. And as mentioned again, you need to have knowledge of the appearance of the ossification centers. Don't worry about that. It might be a lot to know in terms of when the ossification centers, when they appear and when they fuse, but what clues you in is your clinical examination, as well as if the situation you're uncertain, you can get your comparison views, or you can always refer. Also need to look for soft tissue signs on x-rays, such as swelling, and more so that for fat pad sign. Sometimes the swelling can be so significant in that you may get, your tissue planes may not be well delineated. Skeletal surveys mentioned before for suspect child abuse and a metabolic bone disease. So sometimes we order further imaging, and more notably so that of a CT scan. That's mostly for the older child, and if you have complicated intra-articular fractures, because it mainly just similar to just basically a fancy X-ray in different planes. It's not good for seeing cartilage, and that's why I mentioned older child. But for bones that are relatively deep, such as the spine and pelvis, can be beneficial as well. MRI is rarely used, however, there is some benefit to it, especially in environments when its cost is not that much of an issue. Can be used in situations when you're not clear on the X-ray where the fracture is and it's due to the ossification. So it's primary cartilaginous. A classic example of this is the lateral condylar fracture of distal humerus. Can be seen in that middle photograph of the MRI. Unfortunately, pointer, but take my word for it that there is a fractured lateral condyle there. Ultrasound does have a role, and similar to MRI, basically. It's more notably so for epiphyseal separation of infants, especially around the humerus with a proximal or more commonly distal humerus. And that can see in that picture on the right, where you can see that there is a separation of distal and proximal humerus. Now, management just generally for these fractures. So it depends on many factors such as age, location, that is anatomy, not location in terms of where the fracture happened, and that's an old dad joke, and also based on the severity as well as local factors and systemic factors in terms of patient has any comorbidities, etc. Younger child has greater remodeling potential, for example, less than 8 years old, and you may accept less than anatomical alignment and reduction. And I've said that before, I'll say it again. So undisplaced fractures or relatively undisplaced fractures, put that in quotations, can just get away with doing a splint, cast, and you can protect if it's lower limbs, such as offload. Offload can either be crutches, special type of shoes, etc. Displaced would require reduction, that is aligning the bones in a better position. This can either be urgent or emergent. And reduction or manipulation should ideally be done under anesthesia. There is a role for general traction, where, you know, using pulleys, etc., body weight, physics, all that stuff, you can get gradual distraction across the fractured bone ends, and it causes the muscles to relax, and that can be beneficial in getting alignment. This can be done for the upper limbs as well as the lower limbs. Upper limb, we can use the finger traps, etc. Anesthesia, kind of local anesthesia or even regional, such as BEARS, which is IV, intravenous regional block. Or you can actually do nerve blocks or even general anesthesia, depending on setting and situation and patient compliance, etc. After we've got the bones reduced, we need to stabilize it. Just makes sense. It's going to be either done by fixation or casting. Now, fixation is going to keep it simple, can be internal, as you've seen on the right lower one picture there. That's where we've seen 3 different techniques in one limb, poor child. Had screws in the talus, wires, in the distal tibia and a nail, a flexible nail in the femur. And afterwards, of course, you need to have rehabilitation. Now, children, they have another thing with children that's somewhat more unique than adults, is that in terms of rehab, there's benefits and disadvantages in that they are less likely to have stiffness after immobilization for the similar period as that of an adult. However, issues that they have is that sometimes children are not very compliant with the rehabilitation. They're having pain, they just won't do it. So that's why we need to try and optimize their pain control and get them moving and basically back to where they were before the injury. Now, so let's just go from most of the bones. We'll start with the hand and wrist. So hand fractures is about 25% of pediatric fractures totally. So it tends to be more or less bimodal, where you tend to get crush injuries in toddlers because they put in the hands everywhere. And, you know, unfortunately, you might not look and you close the car door or the front door on their fingers, or something falls on their feet. They're just trying to explore the environment and hard to contain. And in adolescents and even younger, like some of the younger pre-adolescents, that's it. They're participating in sporting events, such as some very risky, like motorbike, etc. So in the hands, they start distally, you have phalangeal fractures. In distal, we have a femur fracture, we can see in that picture to the top right. That's where a fracture usually in the distal phalanx and involves the nail bed. The importance of this is that it's an open fracture. And as such, it should be treated like an open fracture with antibiotics, irrigation, nail bed repair, depending on how bad the nail bed injury is. And yes. Now, and also you have mallet type fractures, similar to adults, but it tends to go through the physis. Similar type of treatment in terms of mallet finger splint or even surgery. You can get fractures of the proximal and middle phalanx. This tends to occur usually at the physis. And if it's displaced, may require reduction and splinting. And the splinting should be done in a functional position. Functional position is when the metacarpal phalangeal joints, that's basically the joints where your knuckles are, should be in about flexion, about 70 degrees. And the interphalangeal joints, those are the joints of the fingers, should be in extension, basically. Easy way to remember it, just let the child hold a cup or a mug, and that's the position that the hand should be splinted ideally. Sometimes to make life easy, we just put them in a boxing glove splint where we just roll up some soft roll or cotton in the palm and then just wrap everything with bandage. And it's more or less a fix-all for everything. All right, so you can also get fractures in the metacarpals, and of course, you can get physeal fractures there. And it's displaced, it needs reduction splinting, just as mentioned before, in the functional position. And you can also get fractures of the neck, and this is more in your adolescents when they get very active and they're acting out and their anger issues. I'm sure we are familiar with that. And you can get the examples of boxers fractures. It's not really a boxer in terms of when you're supposed to box, it's supposed to really punch with the second and third metacarpal bones. But in the boxers fractures, that's when they actually miss or actually hit with the fourth and fifth. And you can actually get angulation and somewhat deformity. Now note, because the fourth and fifth are very flexible, those metacarpal bones, you can accept up to 45%, very important, in these injuries, and they'll be fine with no issues. While compared to that of the second and third, can only accept 15% because they're quite stiff. Now, fractures around the wrist and carpus is very rare. That's because a lot of the time, in the child, it is the carpal bones are covered by a cartilaginous shell until about adolescence. Scaphoid fractures can usually tend to peak around 15 years old. Now, in the forearm, as I mentioned before, is very common fracture. It's about 40% of all pediatric fractures. Of these, only 4% are of diaphyseal. So therefore, it goes to show that most of them would come from the distal radius. And it's about 60% of forearm fractures itself. It has great remodeling potential, especially closer to the physis. So if fractures are through the physis, even if it's completely displaced, and the child less than 11 years old, they have quite significant remodeling. Well, you can also, if it's displaced, we tend to do manipulation and casting, but if there's any instability, we can fix it with wires, usually. So you can see in the picture at the top right, that's when we do the manipulation and we place a cast. If the patient had a fracture of the, a Saltire 2 fracture of distal radius. And in the lower picture, to the left, we had fixation with K-wires and an intramedullary nail for the radius. Good. Then the forearm shaft, bayonet apposition, that's basically when the bones are overlapped, but they're aligned. They can be accepted in the very young, and by very young, I mean less than 8. But usually should have an overlap of 1 centimeter or less. So bayonet apposition that's showed in the X-ray in the lower right as well, you can see there. And it's remodel is fine without any issues whatsoever. If there's any displacement, we can do close or open reduction and elastic stable intramedullary nailing, flexible nailing, as you can see in the picture there. All right, in the elbow, what happens in the very young, it's mostly cartilaginous, especially just after birth. This accounts for about 9% of upper limb fractures, and almost 90% of the elbow fractures involve that of the distal humerus. So we'll speak about those in a little bit of detail. These fractures tend to occur around the 5 to 10 year age group, and of course, more so in boys. On the X-rays, repeat, you need to know the knowledge, you need to have knowledge of the appearance of ossification centers. And the mnemonic that we use is Crital for this in terms of the orientation. And God made life easy for us. The way to remember it is that the appearance ossification center is basically 2, 4, 6, 8, 10, 12 years. And where C stands for the capitulum. I'm not sure if you can see that picture to the right. So the capitulum is just above where the radius is. And that's what's common, usually appears at about 2 years of age, followed by the radial head, which is about 4 years. Then the internal, which is sort of mila epicondyle, about 6 years. And at about 8 years, we get the trochlea. 10 years, we will get the olecranon, and the lateral epicondylis last at 12 years. So important to know where these ossification centers are, because otherwise it looks like there are fractures there. Now the fat pad sign, unfortunately, I didn't have I put up an X-ray with it, unfortunately. But here's a picture to the right of the diagram, basically. But what happens is that there normally is a fat pad that just in front of the within the joint itself, and so that when there's any significant effusion or swelling inside of the joint, fluid in the joint, it tends to lift the fat pad, and you see that there is right in front of the bone, you see that there is a radiolucency, and then you see a radial opacity where the fat pad sign is, and that suggests that there's a fracture around the joint. Treatment, just as before, if undisplaced, you can splint, usually in that of an above elbow back slab, or a sling if the child can be trusted. If displaced, then you may need to refer for manipulation, anesthesia, and possibly surgery. Now, let's talk about supracondylar fractures, which is quite common. We see a lot of it, especially in our practice at Bustamante and also privately. It accounts for about 60% of elbow fractures. And basically, management depends mostly on displacement, as well as if there are any other factors, such as if it's an open fracture, etc. So there's undisplaced. These fractures can be missed, and that's where you take into account your lines in terms of your fat pad sign, and then on doing your lateral X-ray, you just want to ensure that the front of the diaphysis of the humerus that it should go through that of the capitellum. Treatment usually involves cast or sling, but on displaced, but just for a period of about 4 weeks or less, just under 4 weeks. If it's displaced, it requires surgery in an urgent pattern, ideally, you know, sooner the better, so to speak, but it's not a dire emergency unless there is compartment syndrome or other issues such as open fracture, etc. And here is a picture, a few pictures of the same child who presented just a few days ago. He was at school and he fell off a wall and sustained, he fell on his outstretched hand and had that deformity, as you can see. He was still in his school uniform when he came to us. You can see the picture on the middle of the x-ray, significant displacement. It's like as far as east is from the west. Thank goodness it wasn't an open fracture. I'd gotten it reduced and would passed KYs across, and he's doing quite well and he's happy and doesn't want to leave the hospital. Talk about lateral condylar fractures now, it's a little difficult one. As you can see in that picture to the right of the x-ray, the top one, sorry, is that red arrow points to that fleck of bone, which basically is the proximal extent, the upper extent of the fracture on the lateral side, the outer aspect of the arm, and it's actually extending all the way downwards inside towards the joint. The reason why we can't see the rest of that, because it's cartilaginous below that part. So it starts from the metaphysis, goes through physis, and into the epiphysis. It is relatively common, so almost about 20% of distal humeral fractures, mentioned before, it can be missed. You may have to order special views or an ID setting MRI. And when in doubt, you know, as I mentioned before, refer. Maybe, so the issue with these fractures is that they tend to have if not treated properly, I should note, it has a worse outcome compared to supracondylar fractures because it involves a joint, all right? So because it's, so to speak, a solitary type 4, as opposed to the supracondylar fracture, which is just purely metaphysical. It can affect the blood supply as well as the growth potential of the affected bones that are fractured. And this can result in joint problems, growth disturbances, as well as deformity. Treatment involves casting or surgery, so casting for the undisplaced, or surgery with KYs and or screws for about 4 to 6 weeks. So in that middle, well, the middle two pictures on the left, you can see that there's an arthrogram, because we had seen a situation where we weren't sure the fracture had gone into the articular surface. So we had injected some dyes under general anesthesia. You can see that there's an outline of the fracture, but with not significant displacement of the articular surface. The same patient would pass 3 KYs and he did quite well. Situations when there's significant distraction, so-called a fracture site over there, if the patient comes a little late, we can consider using screws, or you can just use screws from the get-go. Medial epicondylar fractures, not very common, about 10 to 20% of distal humeral fractures. Usually, some of them are associated with elbow dislocation, almost like 60%. And this tends to occur in the older age group, in the 11 to 12 years age group. Treatment is mostly non-operative, even in situations where it's displaced. And we usually immobilize for a short period, let's say as short as 5 days. And then range of motion exercises because of the problem with stiffness. Stiffness is a huge problem with these, especially in situations with dislocations. But we're not speaking about dislocations, we're speaking about fractures. Great. And you can see the picture there shows where the medial epicondyle is and how much it is. The only time really the surgery if there's instability or if it's actually impacted inside of the joint. Proximal humeral fractures, less than 5% of the fractures, and it's most common in adolescents. Neonates can get transphysial separation, I mentioned before, and that's where ultrasound can help in the diagnosis. Because about 80% of the growth of the humerus occurs at the proximal physis, that the closer the fracture is to the physis, there's markedly great remodeling potential. So you can accept a lot of displacement and angulation, especially younger the child. Especially also because of the range of motion of the shoulder, is that you can really get away with some deformities, even to some extent, a minor extent, rotational abnormalities, which is not really common for long bone fractures. We usually try to correct any rotational abnormalities, or within 10 degrees, I should say. Physician needs to be familiar with the shape of the physis. Now, that's where you have that picture, the top right. So the physis at the front, that diagram, is more or less horizontal, but at the back, you see it's kind of undulates, so to speak. And that has to take into consideration some of the attachments of the rotator cuff, musculature, etc. And the joint capsule tend to run across the physis, so to speak. So that fractures that through the physis are both tend to be intra-articular, and can be seen in the X-ray pictures below. And there's a fracture through the physis, and now looking at it, it just looks like a normal physis, but you can notice that it's somewhat wide, and there's some mild angulation to it. Situations like this, you can have some comparison views, but clinically, if there's any tenderness, then treat it as a fracture. You can't go wrong. And then in the picture that's below it of the X-ray, there's a displaced fracture, which we had reduced and passed KYs to hold it. This can also be fixed by flexible nails as well. Clavicle fractures are very frequent fracture of the long bones, especially in toddlers or the preschool, and also in obstetric, let's not say obstetric, or also in birth fractures. 80% occur in the mid shaft, and 50% the lateral end, and 5% the medial end. What's unique about the clavicle is that the first bone to ossify, and this does intramembranous ossification, and is the last one to ossify. So treatment is almost always non-surgical. In fact, if you see a mid-shaft fracture in a child, we can just put them in a sling if the child will tolerate the sling for about 2 weeks, and afterwards allow them to move. It will 99% heal with no issues. So sometimes we don't even have to follow them up at all. Also need to look out for situations where it may be mistaken that you have a congenital pseudoarthrosis of the clavicle. But let's not speak about that. So briefly on the spine, just because it's quite rare, but just two things I would like to highlight since we're just speaking about fractures. Spine injuries do happen, but it's associated with high velocity injuries. So that's where we're taking our ATLS for a multiple trauma. We get referred a lot of pseudo-subluxation. Now, what is that? So pseudo-subluxation of C2 and C3, that's where the second and third cervical vertebrae, because of the orientation of the facet joint that is horizontal in children as opposed to more vertical, it allows somewhat of movement more than that of an adult. Also because of children's general ligament laxity, and they have a large head, that it can look like there is anterior translation of the C2, the dens, which I'd love to move my arrow to show you, but anyway, we should know where the C2, the dens is. So it's compared the C2 to C3 in that picture of that X-ray on the lower right, that it's significantly anterior translated and it looks displaced. Sometimes it can be as much as 4 millimeters, which in an adult would be horrendous. But in situations like this is just because of what was mentioned. So this is a physiological, not even a variant, it's physiological actually. And the way how we determine if it actually is a true subluxation, or a true subluxation or dislocation versus a pseudo subluxation, we draw a Swiss chalks line. That's where we look at the spinal laminar line of C1 and C3. Spinal laminar line is that line that just from the spinous process, as it meets the lamina, I don't know if this is making sense to y'all, where if you connect it from C1 to C3, that of C2 should fall within 1.5 millimeters of it. Or, well, as well as clinically. So if the child has enough significant tenderness and stuff, can do that. And no neurology, of course, is very important, no neurology. we can do this, or we just do an extension view. If it lines up properly with extension view, it's fine. Or in the situation where the child is small and has a large head, we can just put a roll under the shoulders, so it's on the same level. Now, what is Kiwara? Now, that is spinal cord injury without radiographic abnormality. And this is unique to children, like 10 years and below. And that is what happens because the spinal column, that is, the bone and the ligaments that are around the spinal cord, is much more elastic, pliable, or compliant, whichever you want to use, than that of the spinal cord, and it's 8 times. So in fact, they say that the spinal column itself can actually translate or move, distract 2 inches compared to 1/4 inch for the spinal cord. So what happens that was thought at the time of the injury, the spinal cord and the column moved, but because the spinal cord is not that compliant, it gets significant damage. It can be an incomplete or even worse, a complete cord injury, and the child can be paralyzed without any evidence of bone injuries on X-ray and CT. MRI, of course, will show changes. Now, pelvis. I have to speak about avulsion fractures, and this is where the apophysis comes in. All right. So, can get avulsion of the ASIS, anterior superior iliac spine, and it's usually from your sartorius, can be from the anterior inferior iliac spine, from rectus femoris, from your rami, from your adductors, ischial tuberosity, where you get avulsion from your hamstrings, and also from your lesser trochanter, from your iliopsoas. Usually it's none up, except in the situation of the athlete, because you're having younger and younger athletes. So we can offer them fixation, tend to do a little bit better with surgery, but just shown so in athletes. Or you can have fractures from high velocity multiple trauma, and we can classify it based on if it involves a pelvic ring or not. If it involves a pelvic ring, then it's somewhat more concerned, and if it's stable versus unstable. Treatment, of course, the ATLS, because of the remodeling potential as well as the healing potential in children, a lot of times it's conservative, except if there is significant displacement, and which is rarely the case. Can be treated by external fixators, or you can do internal fixation as well. All right, femur, we're almost there. So femur fractures, we'll have to start at the top. So you can neck of femur fractures, and then this can be classified based on your Delbet classification. It's just whether the fracture is more from proximal to distal. So if it's just below, just through the physis, through the neck, through the base of the neck, or between the trochanters, then treat accordingly. And as you tend to go, the more proximal the fracture is, the worse the outcome is, because of risk of avascular necrosis, because of damage to the blood supply to the femoral head. In the type 1, 1B, sorry, differentiate from SUFE. To have a neck of femur fracture is your more significant trauma, and usually associated with hemarthrosis, etc. Treatment can either be, if it's undisplaced, by spica casting, or if it's displaced, closed or open reduction and fixation and different methods. You try to avoid the physis if it's possible. If not, then you go across with smooth wires centrally, or you can use the implants, which range from K-wire screws to plate and screws, etc. Shaft of femur fractures. Yes, so going back to child abuse. So I said, just to repeat, if suspected the child is less than 18 months, and the treatment of femur shaft fractures depends on the age. I just wanted to break it down, make it very simple. If a fracture occurs less than 6 months, you can use aluminum splint. Situations where Pavlik harness is available, you can use that, but it's somewhat costly for us. So aluminum splint is fine, and the child will heal within 2 to 3 weeks, believe it or not. Less than 5 years, you tend to do traction and spica, or you can move to immediate spica under anesthesia, and that avoids delayed hospitals, prolonged hospital stay, etc. 5 to 11 years, you can use flexible nailing or ASSN, and greater than 11 years, we can use trochanteric nailing or rigid locking nail. Similar to adults, however, you'd avoid the piriform fossa, especially if the proximal physis is still open, because if you go through the piriformis fossa, then there's risk of avascular necrosis as well. Distal femur fractures, that's where it can be treated if it's undisplaced and cast, or you can use screws, but you have to avoid the physis if you're using screws, because compression across the physis will cause a physeal arrest. If you have no choice, then you remove the screws as soon as possible after you get some bony union, or you can use K-wires. So let's run through some of these pictures. So picture at the top right, that was a 4-year-old girl who presented to us. She was unfortunately involved in a motor vehicle accident. She was run over by her aunt. She had sustained or suffered delbit 1 fracture of her neck of femur. There you can see that the hip is dislocated and the epiphysis is off of the metaphysis. And as well, in the same limb, interestingly, she also had a fracture of her distal femur metaphysis. So, I mean, the hip is facing forwards and the femur is facing, the leg is facing to the outwards. So we had fixed her distal femur with cross K-wires, as well as fixed her neck of femur with the K-wires at the top. And she's doing relatively well so far. However, she still is not quite out of the woods, because there is almost 100% risk of avascular necrosis. But, you know, fingers crossed, and the data I've got. And the bottom left picture is just a picture of a flexible nail. Usually we use 2 nails, but in this situation, based on our teaching of nails, we're able to get good alignment with 1 flexible intramedullary nail. And we'll speak about that patient as well, because the child also sustained some fractures further distally. And in the bottom right set of pictures or x-rays, you can see that there's a displaced Salter-Harris 1/2 fracture distal femur, completely off. These fractures, because of the popliteal artery, which is so adherent at the back, the popliteal fossa, high incidence of damage to popliteal artery and nerve damage. So you treat these almost like knee dislocations in adults. What was done was cross K-wires. Child had done quite well. All right, we're going to speak about the tibial fractures. Now, starting proximally, you can get fractures that are intra-articular, such as your tibial spine avulsion. So this is through the epiphysis. And what happens is that the ACL, anterior cruciate ligaments, inserts into the anterior aspect of the tibial spine. And what can happen is that in certain injuries in adults that would cause an ACL rupture, because as mentioned before, ligaments are somewhat stronger than the cartilage, in that they will get an avulsion, and the weaker point would be that of the tibia. And there can be classified based on how much displacement is. You can see in the picture to the top left. And we had a patient here who had, it's somewhat difficult to see, but it's almost like there's a fleck of bone or avulsion of the tibial spine. It was fixed with screws and done relatively well. Can also use sutures, but usually aided with arthroscopy. And but there's a risk of damage to the physis in either one if you go across the physis. All right, so you also have something called a tibial tuberous avulsion, tend to occur in the older age group, as your adolescents. The mechanism of injury is that of rapid deceleration or sometimes acceleration. So it's your long and high jump athletes, so they're very athletic usually in men. Classification based on how displaced it is. So the picture to the right of what I'm discussing, you can see there's mildly displaced or significantly displaced. Now in the type 1A, this looks almost like your Osgood-Schlatter disease, which is just basically your fragmentation or your apophysitis of the tibial tuberosity. So if it's displaced, you're going to fix it with mechanical screws, and of course, same principles, avoid the physis. Tibial shaft fractures is relatively common, and it's thought to be the 3rd most common, depending on if the fibula is fractured as well. talks about the stability. The tibia is fractured alone, it tends to cause some deformity, and the leg tends to turn inwards or varus. So you may need to cast, or you can actually use flexible nailing again. Distal tibial fractures can be physial, or what's unique is that of transitional fractures. That's when children go through the transitional period, when the distal tibial physis starts to close, it goes in a certain routine order of closure. And that, as I said, when the physis closes, it causes somewhat stress rise or stress points that can lead to fractures at certain points based on the age group, etc. This can talk about your triplane or your tilo fracture. In the picture to the lower picture, there's a patient who had such a fracture. It was a fracture that had involved the I think it was a Salter Harris 3, if I remember correctly, and it was fixed with screws. Patellar fracture is not common at all. All right, so the different types, you have to differentiate from a bipartite patella, and this is where your comparison views might come into play, or if there's tenderness, there's a fracture. Can be transverse, or you can also have sleeve fractures or stellate fractures. Transverse can be displaced or undisplaced. Now, sleeve is peculiar to children in that that's where when the cartilage hasn't quite formed in the inferior, when the cartilage in the inferior polar patella hasn't quite ossified and there's rapid deceleration or whatever, it causes avulsion of that sleeve, so to speak, of cartilage. And that can be missed on x-rays because it's purely cartilaginous. What can clue you in if the patella is very high or there's ecchymosis and a lot of swelling, then that's likely the diagnosis, and it's likely displaced and will need surgery if it's displaced. If it's undisplaced, for all these fractures can be treated in a cylinder cast with the knee in extension. Displaced, you can fix with wires, sutures, screws. All right, we're at the foot now. Great. So start with the talus, so the hind foot. Talus fractures are very rare. Usually it can involve the body and the neck. The neck is much more common, but it can get some small avulsion as well, and that's usually in your adolescence, and tend to occur with high velocity injury. To the picture to the right, there was a little girl who had sustained a fracture of femur on the same side as her distal tibia, and she had a fracture through her neck of talus, which was reduced with screws and KYs as seen in the picture. Now, if it's displaced and there's some delay to surgery, even if you get surgery right away, the AVN risk is relatively high. And the higher the grade it is, AVN risk can almost go to 100%. Calcaneal fractures usually occur in the older child and usually occur fall from height. But the good thing about this in children is usually extra-articular. And this has to do with the whole alignment of the cartilage, and the joint surface is more horizontal. So less likely to get that wedge compression through the articular portion of the calcaneus. Can also get avulsion from the base of the fifth metatarsal apophysis. Usually treated with casting. This needs to be separated from isolating disease. And that's just apophysitis of your base of your fifth metatarsal. You can also get metatarsal and phalangeal fractures. I mentioned before, you can get a femur fracture. In the picture to the right is a little girl who had a fracture through her nail bed as well as her distal phalanx, which was treated with nail bed repair, so irrigation, because it's an open fracture, as well as repair the nail bed and fixation with fancy KYs, cannulated KYs. Good. Thank you for sticking through with me, guys. I'm not sure how much of you are still there. These are my references, and yeah, any questions?
Wow, you really took us to the beach. Thank you so very, 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 very much, Dr. Prince. It's amazing. You went from head to toe. So it was sticks and stones may break our bones, and his words certainly helped us to manage common fractures in the pediatric age group. And this entire webinar will be posted, so you want to keep in touch with our administrator, and she will tell you more about it. All right, Health 2000 Canada, I invite you to come and give us more of your presentation, please.
Hello again, Amoy here from H2K, reminding you of some of our over-the-counter solutions. Bor Total, the perfect herbal companion for skin infections and wound healing, specially designed for the pediatric population, for example, in diaper rash and insect bites. The ingredients in Bor Total are neem, aloe vera, licorice, sesame seed oil, asoka, and zinc. This all-natural preparation is safe and effective for babies' delicate, precious skin. Bor Total reduces topical pain, calms minor skin inflammation, treats minor skin infections, and promotes healing. Very soothing for dry, irritated, itchy skin. Bor Total provides plant and mineral ingredients, is natural and organic, contains no harsh chemicals, is sulfate-free and cruelty-free. For diaper rash, Bor Total relieves irritation, pain, swelling and itching, and heals or prevents sores from forming on your baby's delicate bum. Nursing mothers can also use Bor Total if they experience dry, cracked nipples. When bugs bite, apply Bor Total immediately to keep your child happy, as Bor Total provides fast relief from the pain, itching, and discomfort. Bor Total is great for minor cuts, scratches, and minor sunburn. Use Bor Total, a great, safe, effective herbal cream for your child's delicate skin. So for the soothing, healing, and protection of your baby's skin, use Bor Total cream, available in pharmacies island-wide. H2K Vitamax multivitamin and mineral syrup. Vitamax provides 15 essential vitamins, minerals, and trace elements, making it one of the most complete preparation in one spoonful, delivering 11 of the vitamins and minerals your body needs on a daily basis. Vitamax is great for the entire family from age 1 to adults. Taking Vitamax results in less infections picked up at school or nursery. It helps your child heal faster and helps keep them energetic and strong, boosts your immunity. Vitamax is fortified with 75 mg of L-lysine, an essential amino acid important for proper growth of your child. L-lysine boosts your child's appetite and plays an important role in bone and tissue health. Vitamax sweet pineapple flavor without added sugar is a hit with children. Good. Safe for diabetics. So, it's a thumbs up for Vitamax, available in leading pharmacies island-wide. Please ask for it. H2K cetirizine 5 mg per 5 ml solution is the most potent antihistamine, providing effective relief within 30 minutes to 1 hour from symptoms such as sneezing, runny eyes, inflamed blocked nose, itching, and recurring welts in conditions such as perennial rhinitis, seasonal allergic rhinitis, and chronic idiopathic urticaria. Cetirizine may cause drowsiness. The dosage for children 2 to 12 years with body weight of over 30 kg is 10 ml once daily. For children 2 to 12 years with body weight of under 30 kg, the dosage is 5 ml once daily. H2K Loratadine Oral Solution 5 mg per 5 ml delivers fast, non-drowsy indoor-outdoor allergy relief in as fast as 1 hour. from symptoms of runny nose, sneezing, itchy watery eyes, itchy throat or nose. The dosage for children 2 to 12 years with a body weight of over 30 kg is 10 mils once daily, and for those with a body weight of under 30 kg, 5 mils once daily. Glucolite, the best tasting orange flavored oral rehydration salts on the market today, helps prevent dehydration due to vomiting and diarrhea, fever, excessive sweating from heat, exercise, and travel. Glucolite restores body fluids and electrolytes lost due to dehydration. To use Glucolite, mix 1 21-gram sachet in 1 liter of water and consume within 24 hours. Discard any unused portion after. The dosage for infants and children is 1 to 2 liters or 5 to 10 glasses over 24 hours. Double for adults. Continue using Glucolite until diarrhea stops or dehydration is corrected. Did you like what you heard? For samples, please contact me via WhatsApp at 876-878-6125. Thank you and be safe.
Thank you very much, Ms. Strickman. That was from Health 2000 Canada. At this time, we'll answer, how many questions do we have? I believe we have 1 question. So, this question says, as it relates to repair of the nail bed in the Seymour fracture, how is that suture done? And what type of suture do you use, if so?
All right. Okay. Yeah. Very good question. Thank you for that question. With regards to the nail bed, so we usually tend to use like a 4-0 monocryl. It can use so a delayed absorber suture can be used. We would tend to avoid Proline if possible. These are for injuries that involve the sterile matrix. And the germinal matrix, as under the eponychial fold, a little bit more difficult, and it requires even more end-to-end repair. So what we have to do, you'd have to lift up the nail bed, lift the nail plate, I apologize, and irrigate the fracture site as well as nail bed. This should ideally be done on a tourniquet, and then you can, once you get everything approximated, you can suture relative and tension-free, and then you can either reuse the same nail plate after you've cleaned some of the flesh, so to speak, and return it under the nail fold and secured it with non-absorbable sutures, and give a course of antibiotics. If you catch it relatively early, because of the vascularity in children, you can just basically give a start dose of antibiotics if that's the situation, if you get irrigation and stuff right away, or you can give them a short course of oral antibiotics, depending. If that answers the question.
Thank you very much, Dr. Prince. It has certainly been a wonderful feast, and to help move the vote of thanks is Dr. Peter Swaby, AGP Executive Board Member. Dr. Swaby, your turn.
Thank you very much, Aldith. That was a fantastic conference. Thank you for moderating it. And thank you also to Allgate Solutions, our technology platform, which worked quite well today. Just one glitch with one of our presentations in terms of sound, but that was quickly rectified. Thanks to Nestle, JSK, Indus Life Sciences, Arista Pharma, Abbott, and H2K for their support of our conference as well as their presentations. For Dr. Curtis Pryce, who gave a very clear presentation and assessment of the treatment of asthma in the various age groups. Prof. Celia Christie, who did a fantastic job with the epidemiology of current URTIs and LRTIs, updates on SARS, COVID-19, RSV, influenza, measles, and mycoplasma. It was a comprehensive discussion and presentation, and reminders of diagnosis and management. And for Dr. Shom, Prince, for a very clear and graphic presentation of common fractures from head to toe, clear with useful pointers on management and referral. Thanks to Aldith. Thank you, Aldith, for doing the entire conference and moderating it so well and with such energy. And to our president, Donald Gordon, and our executive and admin team, Lynn and Suyen, for their continuous hard work and excellence in executing our conferences. And to all our participants, thank you for choosing to spend your afternoon with us and contributing to our discussions and learning. I think we will have our post-test questionnaire posted to the chat, so we can fill that out and be sure to get our CMEs. Thank you so much for attending. We appreciate your support of the AGP, and we look forward to seeing you at the next one. All right. Have a great evening. Go get some dinner. All right. Bye. Can we have that post-test questionnaire put so that we can do that? Okay.